Am I visible decently?
Yes, doctor. Yes.
Yeah, good job. Yeah.
Good evening to each and everyone over here. I am thrilled to welcome you all for today's informative webinar on From First Pain to First Cry, Decoding the Stages of Labor. I am Vijay, manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker of the day, Dr. Navonil Dutta. Dr. Navonil has completed his MBBS and earned his fellowship in cardiology from Mediversal Academy, an award-winning clinician. He secured Best Case Presentation at Consciences 2019 from JIPMER, Puducherry, reflecting strong clinical reasoning and academic excellence. He trained in pulmonary medicine at EIG Hospital, Hyderabad, and served relentlessly as a frontline physician during COVID 19 from 2020 to 2022. Continuing his duties despite personal illness, a testament to his resilience and professional integrity. Deeply committed to lifelong learning and mentorship, he takes holistic interest in cognitive neurosciences, behavioral sciences, and interventional psychiatry. Over to you, doctor.
Thank you. Thank you so much, Vijay sir, for this wonderful introduction. Uh, Before I begin, good evening to all. Happy Valentine's Day to all of you. I hope wherever you are in and around your loved ones, not necessarily romantic partners, but anyone whom you love. I just hope and wish and pray that all of you are doing well with your loved ones, doing hale and hearty. And on this day, before I begin the webinar, the only one request, if I have to have for all of you, is wherever you are, whichever part of this world you are, if you love a person, if a person has made some difference to your life, it may be a mentor, it may be a teacher, it may be your partner, it may be your sibling, it may be anyone. Just let them know how important they are. Let them know that you are grateful to them, and let them know that you love them. Because at the end of the day, uh, I mean, in a world as rushed as it is today, I feel we do not take out much time to tell people at their faces that we love them and that they have made a difference in our lives. So if there's anyone around you, with you, who has made a difference to your life in the most positive ways possible, even if they've done one thing that has changed your lives, tell them how much you love them and appreciate their presence, acknowledge their presence. So with this, I'll be beginning today's webinar. Uh, on a personal note, this is my birthday today. So as I turn, as I step into another year, I would absolutely, you know, I think this is the reason why I chose this topic today. Usually, I have always been taking sessions of medicine or integrated sections of medicine, be it pulmonology, be it rheumatology. But the reason for taking this topic up today uh, of an obstetrician, the topic of obstetrics today, was primarily because I wanted to, get back to this cycle. I know I cannot get back biologically to that cycle again, but definitely what I can do is I can, help you go through the journey of labor, go through the journey of the first pain to the first cry. When I say the first pain, it's the true labor pain, and the first cry is the cry of the fetus. And we all know how special that first cry is. We all know how important that first cry, a good first cry is. So to all my fellow colleagues, my doctors, my juniors, or my seniors, uh, I seek blessings from you on this day. I seek your good wishes, and I hope that I will be, able to make a difference in your lives in the most best ways possible. So thank you for wishing me on my birthday today. So here's the Valentine boy beginning the journey today. And before I begin, there'll be one thing which I want to say, that uh, I'm currently a little outside, like out of my home. So I want you all to put a big hand, or at least put some clap emojis for the person who is going to be on the other side of the screen. That is Dr. Rimjim Rastogi. She happens to be my friend and my colleague, and she'll be the eyes of me today in this webinar, because as I said, I'm not located at my current place of stay currently. So she'll basically be guiding me through to the entire slides and the sessions. And I really appreciate Dr. Rimjim taking out this time to do this. And a big thank you from my end and everyone here at Mediversal. And whatever success this webinar comes out into, a part of it will always be owed to you. So thank you for this. So I hope you all are good. I hope you all are well set, and I hope we can begin today. Everyone's good. Good evening to everyone. I won't be able to read much of your chats today, as I said, because of some technical issues. But I will intermittently be going to your chats. I will be reading, and I promise to be replying to as many as I can. So good evening, good morning, wherever you are, whichever part of this world you are, whichever time zone you are. Let's begin, and let's begin with the best of minds. So that's our first slide, from the first pain to the first cry. And just a minute. Am I visible? Can
Yes, doctor, you are
Yeah,
visible.
very good. Okay, good. So as I always begin, I always put put a slide of gratitude to the ones who have taught me, and that is exactly from where I begin almost every webinar that I've taken since a very long time now. So we'll be moving on to our first slide of the day, and the name of the slide is rightly Baby's GPS. So what is basically labor? What are the terminologies or basic terminologies of labor? That is exactly what we'll be talking about. And once we get through that phase, we'll be gradually starting to move forward with the further topics. So we have certain terminologies that I want you to know. One is lie. What is lie? Lie is basically the relationship between the long axis of the centralized uterus and the long axis of the fetus, which means if the if the uterus is this and the fetus is also this, then I can call it as a longitudinal lie. If the uterus is this, but the fetus is lying like this, it's an oblique lie. And if the long axis of the uterus is like this and the fetus is lying like this, it's a transverse lie. So basically, there are three possible kinds of lies that can be present. The most common lie being longitudinal. And next is what we call as presentation. It's the part of the fetus that occupies the lower pole of the uterus. Here in this diagram, you can clearly see that it is the head which is occupying the lower pole of the uterus. So that's what we call as the cephalic presentation, which is the most common presentation indeed that we see. And there are some other malpresentations which are not the normal presentation. That is breech, where the baby's buttocks will be the ones that will be occupying the lower pole of the uterus. And in some cases, there might even be a shoulder presentation if the baby is lying transversely. So these are basically some typical other presentations apart from the cephalic presentation. But as I said, cephalic happens to be the most common. Now let's come to what is called presenting part. Presenting part is basically the part of the presentation. What is presentation? It's the part of the fetus occupying the lower pole. This may be if I find which part of the fetus exactly is lying over the internal os. That is the part that will be felt on the per vaginal examination, right? When I put my fingers into the vagina of this pregnant lady, the part that I'll be able to feel on my fingers, that is exactly the presenting part. So the part of the presentation that is directly felt on per vaginal, exactly over the internal os, that is what we call as presenting part. And if you understand that in a cephalic presentation, I mean, if the head is the presenting part, you can imagine me as the fetus. This is the internal os, and you're moving in from here. You're trying to move and touch which part of the fetus is occupying the lower pole of the uterus. You'll find there's a head. So this is the cephalic presentation, which means my head is occupying the lower pole of the uterus. Even in the head, based on which part you're touching. If I say head, you may be touching this part, you may be touching this part, you may be touching this part. Based on how my head is, if it's in a completely flexed state, you can see, is everyone able to see me? Is everyone able to see my head movements? This is my normal head movement. This is me normally looking. Now, when I flex my head, you are able to touch this part on per vaginal, and this part is what I call as the vertex. This part is what I call as the vertex. So, whenever there's a complete flexion of the head, the denominator, I mean, the presenting part that you have is basically the vertex. Whereas if I deflex the head a bit, that means this is my normal head, this is my complete flexion. अगर मैं इन दोनों के बीच में कुछ रखता हूँ, something like this, and there's a deflexed head, you'll again be able to feel something which is the vertex. However, if I start extending my head now, this is a partial extension, this is a complete extension. When I'm doing a partial extension, what you're able to feel is my bro. What is bro? Bro is the part in between the anterior fontanelle and the root of the nose. So anything in between the anterior fontanelle and the root of the nose is what I call the bro. So whenever I'm partially extending my head, when somebody is doing a vaginal, they'll be able to feel this part, which is the forehead part, that's called the bro. And if I extend my head completely behind, and somebody is doing upper vaginal now, they'll be able to find my face, which will be the part that they'll be feeling. So on a complete extension, we'll be finding a face presentation on I mean face being the presenting part. On a partial extension, you'll be finding brow as the presenting part. On a deflexed head, you'll be again finding vertex as the presenting part, and even on a complete flexed head, you'll be finding vertex as the presenting part. Is this clear with everyone? I can see the chat boxes. Can you please type your messages out quickly? Is this part clear? Is this part clear to everyone? Because initially these two slides are the most difficult parts. So yes, okay, Dr. Anjali, thank you. A few more responses before I'll move ahead. I'll be quickly summarizing what I said. Lie is what is the longitudinal axis of the baby in relation with the longitudinal axis of the uterus. Denominator is the part of the fetus which is occupying the lower pole of the uterus. Usually it is cephalic, that's most common. Sometimes it can be the buttocks, that is the breech presentation. Sometimes it can be the shoulder, which is the shoulder presentation. Now, a part of the presentation which is occupying exactly the part over the internal os, which is felt per vaginally, that is exactly what I call as the presenting part. And when I say a presenting part, I can have three things. Either my head is completely flexed when my presenting part will be vertex, or when my head is deflexed, again, it will be the presenting part is vertex. And both of these, if you see, are a part of cephalic presentation. So cephalic is the presentation, vertex is the presenting part. Cephalic is the presentation, vertex is the presenting part. So vertex will be the presenting part in a cephalic presentation only when there is two posture of the head, either a complete flexion or a deflexed head. So either a complete flexion or a deflexed head. Both in dono case mein, head is the or cephalic is the presentation and vertex is the presenting part. Whenever there is a partial extension, brow is the presenting part. Whenever there is a complete extension, it is the face which is the presenting part. Is everything all of this clear? All of this clear? Okay, now we'll move ahead with what is denominator and attitude. What is denominator? It is a bony point of reference on the presenting part. As I said, vertex is the occiput. So that is the denominator. For face presentation, when there is complete extension, the baby is looking like this, stargazing, बच्चा ऊपर की तरफ देख रहा है, and you feel per vaginally, you feel the face. So mentum is what we call as the denominator. And if it's breech, where the buttocks are facing the internal os, and you feel per vaginally, you feel the baby's sacrum. You feel the baby's sacrum. That is the tailbone, basically, sacrum and the coccyx. So in breech, the denominator is sacrum. In face presentation, the denominator is mentum, whereas on vertex, the denominator is the occiput. I think that is clear. Now, what is attitude? It is the relationship of the fetal parts with respect to one another. When I talk of a cephalic presentation, so the head is the presentation, vertex is the presenting part, and this can only happen if the baby is doing like this. If you can see, the baby's arms are flexed, the baby's neck is completely flexed, which means compared to the other parts of the body, the baby is in an attitude of flexion. However, when I talk of a brow presentation or maybe a face presentation, where it is like this, when brow and face are the presenting parts, then the baby is extended, the baby's head is extended compared to the other parts of its body. So that is exactly what I mean by attitude. So most common attitude is flexion. In case there is more than one baby, how will the baby? Okay, we are talking of a singleton pregnancy here. I will take up questions on multiple pregnancies, but I don't think multiple pregnancies are the topic of the day today. If there's a multiple pregnancy, we will have to look at the USG, and the USG will completely tell us what is the presentation. In fact, all of this, whatever I'm saying, are all USG findings. And on the onset of labor, जब हम pelvimetry करते हैं, when we are doing a pelvic examination with a per vaginal, that is exactly when we find what is the presentation or what is the presenting part. That is exactly how we can confirm. Attitude and lie are mainly confirmed on USG examinations or on the Leopold maneuvers, that is the clinical maneuvers that we have in obstetrics. Is that clear? Okay, I will be taking up questions in a bit. I'll be completing a slide and then taking up the relevant questions, because this is in medicine, so I'll go in a more systematic order. So now, based on this, we are going to have certain things which I'll be talking of. We have this picture on the right side in green, as you can see. You can see that the lie is longitudinal here because it is in line with the long axis of the uterus. The presentation is breech because it is the buttocks which are occupying the lower pole of the uterus, and the denominator, which is the bony landmark of the presentation, is basically the sacrum. Is that clear with everyone? Right. Now, based on this, so basically, I can have 8 different positions, and these positions are nothing but they are decided as what is the denominator to the maternal pelvis. Means what is the bony landmark that is exactly lying over the internal os. Based on that, we have 8 different positions that can happen in case of labor. Now, we'll start with the first position, that is LOT. So, Rimjim, I want you to, yes, that's LOT. That's the first position. The second position is LOA, that's left occipital transverse, left occipital anterior. Then we have a OA, or a direct OA, that's a direct occipital anterior. Then gradually moves to the right, that is right occipital anterior. Then moving to the above one, that is right occipital transverse. So now we have talked of 5 positions: LOT, LOA, DOA, ROA, and ROT, which means these 5 positions are basically the positions which will favor a normal vaginal delivery. Yeah, that's great. That's great. We can zoom in. So all these things will be positions 1 to 5, that is LOT, LOA, DOA, ROA, and ROT, are the 5 positions which will favor a normal vaginal delivery. However, positions like ROP, OP, and LOP, they are not going to be favoring a normal vaginal delivery, and will usually the baby will be delivered in C-section unless the fetus rotates itself to come into any one of the favorable 1 to 5 positions. Okay? I know it's sounding a bit Hebrew. Let's break it down a little bit. What is occipital transverse? What is occipital anterior? Yes. Now, please zoom into the bottommost animation, Richard. Please zoom into this. Can you please zoom into this? Yes, that's great. That's great. So, do you all know that there are 2 fontanelles that we have in the fetal skull? One is the anterior fontanelle, the other is the posterior fontanelle. Anterior fontanelle is rhomboid in shape, whereas the posterior fontanelle is what is triangular in shape. And it is this posterior fontanelle that we call as the occiput. Right. Now, how do you identify what is the position of the fetus in relation to the maternal pelvis? Okay. One thing we can clearly understand, that there's a maternal pelvis and there's a fetal skull which is there inside it. That is our diagram right now. In the maternal pelvis, we can very well identify that the anterior most part is the pubic symphysis, where Rimjim is actually pointing the pointer, and the posterior most part is nothing but the sacrum, where Rimjim is pointing the pointer right now. So anytime I will check a maternal pelvis with a fetal skull in it, my first part is to check where is the fetal occiput. So in the first picture, we are having the triangular shaped posterior fontanelle, or the fetal occiput, anteriorly, right? It is anterior. It is facing towards the pubic symphysis. Now, something that is towards my left is actually towards the mother's right, because I am going to see this pelvis from below. You understand? When the mother is lying in front of me, I'm going to see this pelvis from below. So something that is my left is the mother's right, and something that is my right is the mother's left. So whenever in the first image I'm saying that the posterior fontanelle, that is the triangular shaped posterior fontanelle, is facing anteriorly towards the mother's pubic symphysis, my position becomes occipito-anterior. Because the occiput is towards my left side, it is definitely towards the mother's right. So the position becomes ROA, right occipito-anterior. Is this clear to everyone? Is this clear to everyone? I want your chat boxes. I want responses to be very active. Yeah, that's great. Let's move on to the third image, because the second image is extremely easy. So the third image, I want you all to see this. If you see this, that the triangular shaped posterior fontanelle is actually facing anteriorly. Yes, it is facing towards the pubic symphysis. So again, the position will be occipito-anterior, but this time it is facing towards my right, that is the mother's left. So it is left occipito-anterior. Do you realize that if it had to be occipito-posterior, if at all, this triangular shaped fontanelle should have been facing towards the sacrum? Can we zoom in? Yes. Can we zoom in there, Jimmy? Yes, great. So you can clearly see, I think another bit of zooming in would have helped. Another bit of zooming in.
It's not possible.
It's not possible. Okay, koi baat nahi. But based on whatever the fontanelle diagrams I've shown you, just take me back to that fontanelle diagram, the hand drawn sketches. Yeah, just zoom me that. Yeah, zoom me that, please. Yeah, if this posterior fontanelle was facing the sacrum instead of the pubic symphysis, then it would have been left occipito-posterior. Okay, is that clear? Is that clear with everyone? Good. As I said, 5 positions, that is LOT, LOA, DOA, ROA, and ROT. These are the 5 positions where a normal vaginal delivery can be possible. Between positions 6 to 8, where the occiput is facing posteriorly, that is what we call as a mal position, or we call as occipito-posterior delivery. Is that clear? I hope this is absolutely clear. Okay, now I've already talked of you how to identify the fetal positions with respect to the maternal pelvis. So that brings an end to the slide of baby's GPS. I would now take up doubts. I would switch to the chat box to hear if there's any doubt. I'll just give you 2 minutes. Quickly post in your doubts. Quickly post in your doubts. Is there any doubt? Is there any place where you couldn't understand? Everyone's clear with this? No doubts? That's great. That's great. You're having almost 80 participants. I'm so glad. Okay, thank you. Thank you. No doubts as of now. Okay. Okay. We'll be moving in now to this slide. And this slide is rightly saying where every centimeter matters, because this is the time where we need to know that whether the maternal pelvis is having a diameter good enough, or whether the dimensions of the maternal pelvis is good enough for the baby to pass through. Or conversely, is the dimensions of the baby means the baby's skull, is the dimensions of the baby's skull good enough to pass through the maternal pelvis? So we'll be talking in very brief about maternal diameters, pelvic diameters, or maternal pelvimetry, and fetal skull diameters at the same point of time. I know this looks very information rich, very difficult to remember, but trust me, I'll make it as simple as possible. Okay, so I'll request Rinjam to please zoom into the maternal pelvis diameters. Whenever I talk of maternal pelvis diameters, now when I talk of a maternal pelvis, let me try showing if I have something to show you. Just give me a moment. Yeah, I think I have something. Again, perks of not being at home. If this is the pelvis, and this is the inlet of the pelvis that I'm seeing. So this is the inlet. This inside will be the cavity, and here will be the outlet. You realize that if this is the inlet, उसके नीचे cavity होगी, pelvic cavity, उसके नीचे outlet होगा. So the baby has to basically, with uterine contractions, this baby has to come through the inlet, go into the cavity, and then come out through the pelvic outlet, following which the baby will be delivered. Is this clear to everyone? Is this clear to everyone? Yeah. Please, yeah, zoom the slide, but yeah, we are not able to see the left half of the slide. Yes. No, we are not able to see the left half of the slide where I want to talk of the maternal pelvic diameters. Yes, I want to see this slide entirely. Zoom it in a way where I can see it entirely. Okay, it's not happening. Okay, zoom out a bit. I'll take care of the rest. Zoom out a bit, please. Yeah. Okay. So whenever I talk of diameters, I'll be specifically talking of pelvic inlet diameters. A few things about the cavity diameters, क्योंकि वो उतना important तो है नहीं. But the major diameter that is important is the pelvic inlet diameter, क्योंकि baby को घुसना है at least. जब घुसेगा, if the baby is entering into the pelvic inlet, the uterus will contract and then the rest of the procedures will begin. So whenever I talk of pelvic inlet diameters, I'm going to have two things. One is the antero-posterior diameter. कोई भी चीज की, if this is the pelvic inlet, it is going to have a transverse diameter and it is going to have an anterior-posterior diameter. See, this is the antero-posterior diameter of this, and this is the transverse diameter. Do you agree? At any point of time, I should be knowing that whenever there is a pelvic inlet, I will have to deal with two diameters. That is a transverse diameter and an antero-posterior diameter. Do you realize that the transverse diameter of this inlet is always bigger than the anterior-posterior diameter? The transverse diameter of the inlet is always bigger than the anterior-posterior diameter. So, अगर कुछ चीज already बड़ा है, I do not really have to think about the transverse diameter in clinical obstetrics, because the baby will automatically pass through that. The smaller diameter of the inlet, that is the antero-posterior diameter, is what the baby needs to cross. So we'll be talking about 3 diameters here, and these are the 3 pelvic inlet antero-posterior diameters. I commonly tell you to remember it by the mnemonic TOD, TOD, that's the true conjugate, obstetric conjugate, and the diagonal conjugate. Now, if this, now please see me very clearly. Are you all able to see this bottle, the tip of the bottle at least, and this yellow thing that I'm having? Can I have the chat boxes alive? Are you able to see this? Are you able to see what I'm trying to show you? Is this bottle visible? And is this Yellow thing visible. Yeah, good. So now imagine this is the pubic symphysis. Imagine this is the pubic symphysis. Imagine this is the sacrum. Do I know this? That sacrum lies posteriorly and pubic symphysis lies anteriorly. Do I know this? So if I draw a line from the sacral promontory, that's the highest point of the sacrum, to the upper border of pubic symphysis. See, this is the upper border of pubic symphysis. This is the sacral promontory. So I'm drawing a line between the sacral promontory to the upper border of pubic symphysis. This is what I call as the true conjugate. And this usually measures 11 centimeter. You might find a little bit of change in the data here, but trust me, I'm giving you a round up figure. It's 11 centimeter. You can't see. Somebody saying, I can't see. That's Dr. Okay. Again, this is the sacral promontory. This is the pubic symphysis. Anteriorly pubic symphysis, piche sacral promontory. Is this visible right now? I'm drawing a line from the sacral promontory to the upper border of pubic symphysis. Upper border of pubic symphysis. This is what I call the true conjugate. Okay. Now, when I draw a line from the sacral promontory to the middle part of pubic symphysis, that is what I call as the obstetric conjugate. And if I draw a line from the sacral promontory to the lower part of the pubic symphysis, that is what I call as the diagonal conjugate. So basically, my posterior reference point and my anterior reference points are common. The posterior reference point is the sacrum. Suppose I am the sacrum. Try to show it this way. I think up so much mag. Are you able to see me and this? Is this visible now? Am I visible and is this visible now? Am I visible and is this visible now? Is the yellow thing visible? Is the yellow box that I have in my hand visible?
Doctor, slightly visible. If you can bring that to closer to camera, that would help.
Is this visible now?
No.
Is this visible now?
No, doctor, no.
Now?
Yeah, now it is.
Okay. Am I visible? Is my face visible?
You are visible.
Yeah, okay. So if I am the sacrum and this is the pubic symphysis, this is the upper border of pubic symphysis, this is the middle border of pubic symphysis, and this is the lower border of pubic symphysis. If you draw a line from me to the upper border of pubic symphysis, this is the true conjugate. If you draw a line from me to the middle border of pubic symphysis, this is the obstetric conjugate. And if you draw a line from me, which is till the lower border of the pubic symphysis, that is what is the diagonal conjugate. Is this clear with everyone now? TOD, true obstetric and diagonal conjugates. Is this clear? Okay. Now, the value of true conjugate is usually 11 centimeter. The obstetric conjugate is usually around 10.5 centimeter. And trust me, this is the most important AP diameter that we need to talk about. And the diagonal conjugate is around 12 centimeter. So if you realize TOD, let's write the numbers. TOD, it's 11, 10.5 and 12. 11, 10.5, 12, which means सबसे छोटा जो AP diameter है, सबसे छोटा AP diameter is nothing but the obstetric conjugate. Which means agar baby obstetric conjugate, agar baby ka skull, if the baby's skull diameter cannot cross the obstetric conjugate, this baby will not be able to be delivered properly. Which means in any scenario where the obstetric conjugate is less than 10.5 centimeter, it is a contracted pelvis. Can I say that? Pelvis is chota. If the AP diameter of the inlet, baby has to enter through the inlet, come out through the outlet. Agar baby inlet में ही नहीं घुस पाएगा, because the AP diameter, that to the obstetric conjugate of the AP diameter of the inlet is the smallest diameter, that's 10.5 centimeter. If a pelvis has a obstetric conjugate which is less than 10.5 centimeter, can I say that the pelvis is so contracted that the baby cannot enter the inlet? Can I say that? Can I say that? Everyone? I want your active participation. Can I say that? Yes, fantastic. Okay, so I'm repeating the three diameters TOD, that's true conjugate, 11, obstetric conjugate, that's 10.5, and diagonal conjugate, that is 12 centimeter. Now, what is this finger that is showing? The only diameter out of these three that we can clinically measure, during pelvimetry is the diagonal conjugate. Now, whenever we can measure the diagonal conjugate, if we subtract almost 1.5 or 2 centimeters from it, that gives us the value of obstetric conjugate. And if we subtract 1 centimeter from it, that gives me the value of true conjugate. So basically, the only measurement that I can do is the diagonal conjugate. Once I have the diagonal conjugate, suppose my diagonal conjugate comes out to be 13 centimeters. Suppose. What is my obstetric conjugate going to be? It is going to be 13 minus 1.5. or 13 minus 2, whichever makes it easy. 13 minus 1.5 is 11.5, which is decent enough for the baby to pass in. So this is no more a contracted pelvis. But what if my diagonal conjugate is 11 centimeter? If my diagonal conjugate is 11 centimeter, or say if my diagonal conjugate is just 10.5 centimeter, then the obstetric conjugate becomes 10.5 minus 1.5, which is almost 9 centimeter. And now I can call this pelvis as a contracted pelvis. So I will have a different slide on contracted pelvis, which will have three criteria. The first criteria being the AP diameter of the inlet, especially the obstetric conjugate, being less than 10.5 centimeter. That makes it a contracted pelvis. What do I mean by a contracted pelvis? ये pelvis कोई भी बच्चा को इनलेट में घुसने नहीं देगा. ये pelvis कोई भी बच्चा को इनलेट में घुसने नहीं देगा. Do you understand that the fetal diameter can change in every pregnancy, but the maternal pelvic diameter is going to be constant? यानी कि मदर की pelvis की diameter वही की वही रहेगी हमेशा. Depending on the bacha that she is bearing in subsequent pregnancies, the bacha ka fetal head diameter may change. But if the pelvis itself is contracted, it means no baby will be able to pass through the inlet, which means that the management of any contracted pelvis is always going to be via cesarean section. You can never manage a contracted pelvis with normal vaginal delivery. Or never manage a contracted pelvis with normal vaginal delivery. Yes, thank you, Rimjim. So as I said, if the obstetric conjugate is less than 10 centimeter, it means that this baby will not be able to cross the inlet. अगर वो inlet ही cross नहीं कर पाएगा तो cavity outlet तक पहुंच भी नहीं पाएगा, no matter how active the uterine contractions are, because the baby will be like mama का रास्ता, mama का pelvis passage is smaller for me to pass. And because mama's pelvis diameter is always going to be constant, no matter what, mama's pelvis diameter will never change. Baby का skull का diameter can change. ये बच्चा छोटा हो सकता है, दूसरा बच्चा थोड़ा बड़ा हो सकता है, doesn't matter. But mama का pelvis diameter is always going to remain the same. Because of this, anytime we face a contracted pelvis, anytime we find that the diagonal conjugate we have measured and minus 1.5 is giving us a value which is less than 10, we will call it a contracted pelvis, and the management is straight away going to be cesarean section, no matter what. Okay, is this clear? Now we are done with the AP diameters of the inlet. As I said, the clinical pelvimetry will be only measuring the diagonal conjugate. Now we'll be talking of the cavity. In cavity, there's only one thing that I want you to know, that is the plane of the least pelvic dimensions. Now, the plane of the least pelvic dimensions is basically at the level of the ischial spines. Now, what are the ischial spines? Yeah, here, Rimjim, can we, yes, that's the ischial spine, correct. So the outpouching that is coming out, the bony outpouching that you are finding from the ischium, that is exactly what we call as the ischial spine. So if I have to name this place, this is called the place of the least pelvic dimensions. And this is one of the most important parts of the pelvic cavity, because at this place, this is the marker for the descent of the fetal head down. At the level of ischial spines, we are having a station which is called a zero station. Yani ki agar baby zero station cross kar gaya, it will have a easy feasibility of being delivered via the normal process of vaginal delivery. Are you getting me? This is the ischial spine. This is the level of ischial spine. And because the ischial spine is an outpouching, idhar se bhi ischial spine hai, idhar se bhi ischial spine hai. So this diameter that you'll be finding, that is the interischial diameter or the interischial diameter. Yes, that interischial diameter is very small. It is around 8 centimeter. Anytime the interischial diameter is less than 8 centimeter, do you realize कि baby inlet से तो घुस जाएगा, लेकिन cavity से निकल नहीं पाएगा. Anytime the interischial diameter is less than 8 centimeter, baby will cross the inlet, but cavity से घुस नहीं पाएगा. अगर वो cavity से नहीं घुस पाएगा, it will not be able to come out through the outlet. So the baby will not be able to be delivered. So another like criteria for a contracted pelvis, along with the obstetric conjugate being less than 10 centimeter, is also an interischial diameter being less than 8 centimeter. Is that clear? In other words, often as obstetricians, we say, if you are able to touch the both ischial spines simultaneously with the fingers of the same hand, I'm moving my fingers in. So this is the pervaginal. I'm moving my fingers in. And now if I'm able to touch both the ischial spines with the same hand, then it clearly means that the interischial diameter is less than 8 centimeter. It's a contracted pelvis, and this baby will not be able to be delivered via normal vaginal delivery. The management is always going to be a C-section. Is this clear? Now, a few other points regarding the clinical significance of this plane of least pelvic dimensions. The internal rotation of the head occurs at the level of the ischial spine. What internal rotation is, I'll take you through when I talk about the cardinal movements of labor. There's a particular muscle called the levator ani, which hangs from the ischial spine. It hangs like a hook or a hammock, which provides a support. So when the baby is descending, it hits the levator ani muscle and then goes up. Again, the baby comes down with the contraction of the uterus, hits the levator ani muscle and goes up. So this hook-like muscle is the levator ani, which is at the level of the origin of the ischial spines. Number two, internal rotation of the fetal head occurs at this place. Number three, fetal head station is 0 at the level of the ischial spine. And because the interischial diameter less than 8 is a big problem for the fetus to pass through, that can lead to a phenomenon called deep transverse arrest. So the transverse interischial diameter being less than 8 centimeters makes the baby difficult to pass through, causes an arrest of labor. Hence, this is the most common place where you have a deep transverse arrest occurring. Is this clear? Also, from the anesthesia point of view, this is also the place where you give a pudendal nerve block. This is also the place where you give a pudendal nerve block. And you know, when you're giving a pudendal nerve block, what is the ligament that you are trying to paralyze? So what is the muscle that you're trying to paralyze? It is the sacrospinous ligament. Please remember this is the sacrospinous ligament, which is pierced to access the pudendal nerve. So whenever you're giving a pudendal nerve block for anesthesia, you need to access the sacrospinous ligament to give the block. And when will you give a pudendal nerve block? Whenever you will be doing an instrumental delivery. What is an instrumental delivery? चाहे वो forceps से हो या vacuum से. If you are going to give an instrumental delivery like pudendal, like forceps or vacuum, that is exactly you will be when you will be piercing the sacrospinous ligament and you will be accessing the pudendal nerve to give a block. So these are the major parts of the least pelvic dimensions. The outlet diameter is not a big part. Trust me. अगर बच्चा inlet और cavity निकल गया है ना, तो वो outlet से निकल जाएगा. ज़्यादा बड़ा problem नहीं है. So the outlet diameter is not something that we will be actually talking much. However, there is this one diameter which is the bituberous diameter. Tuberosity is basically the ischial tuberosity. जिसके ऊपर हम अभी बैठे हैं. The buttocks, the bony prominence of the buttock is the ischial tuberosity. इन दोनों के बीच का जो diameter है, this diameter is something that should be between 8 to 9 centimeters. Anything which is less than 8 centimeters again makes it a contracted pelvis. So there are 3 diameters predominantly that we need to remember. वो जो पूरा बड़ा slide है उसका इतना कुछ नहीं जानना है. One thing we need to know: 80 diameters of the inlet is TOD. T is 11, O is 10.5, D is 12, O is the shortest. D is the only one that can be measured clinically. D minus 1.5 is O. If anything, anytime O is less than 10, it is a contracted pelvis. Now we'll come to cavity. Interischial diameter at the level of ischial spines, anytime less than 8 centimeter is a contracted pelvis. And outlet may the intertuberous diameter, that is the diameter of the ischial tuberosities, that anytime being less than 8 is again a contracted pelvis. And the management of contracted pelvis is always a cesarean section, because this mother can, no matter what is the size of the baby, this mother can never have a normal vaginal delivery because her rasta itself, the passage itself is short. चाहे कोई भी बच्चा हो वहां से नहीं निकल पाएगा. Clear? Is that clear with everyone? Is that clear? Okay. Now let us go to the fetal skulls. I will, before I touch the fetal skull, I will ask whatever doubts you have. Can you please quickly mention in the chat box whether there's any doubt that you're having with respect to whatever I've said? Any doubt with respect to whatever I've said? How can we assess inlet? CPD, please review again. Okay, CPD तो मैं बोल दूंगा. I have not yet talked of CPD, my dear. Inlet is assessed, yes. So as Dr. Imsim has replied, inlet is assessed by the diagonal conjugate. You measure the diagonal conjugate. What is diagonal conjugate? It is the diameter from the sacral promontory to the lower border of the symphysis pubis. So whenever we put our fingers in, ये वाला जो section है, देखो आप, you put your fingers in through pervaginal, this वाला part that is remaining, this actually is the diagonal conjugate. जितना आपको मिलता है इसमें स्केल से मेजर कर लो, इससे -1.5 कर लो, you will get your obstetric conjugate. And you'll also get the true conjugate. ठीक है? If the obstetric conjugate is less than 10, it's a contracted pelvis. Straight away go with cesarean section. And again, I'm saying it's a contracted pelvis. It's not a CPD. CPD is a cephalopelvic disproportion, जिसके बारे में मैं थोड़ी देर में बात करूंगा. CPD and contracted pelvis are two completely different terms. Contracted pelvis मतलब the mother's passage is छोटा, universally छोटा. उससे दुनिया का कोई भी बच्चा नहीं जा पाएगा. No matter how many pregnancies she has, this pelvis is smaller universally for any baby to pass through. What is a CPD? CPD is a cephalopelvic disproportion. यानी कि for this बच्चा the pelvis may be adequate, but for the next बच्चा the pelvis may not be adequate. ठीक है? It's okay. Let me give you a real life example. Okay. So how many of you have had heartbreaks in life? Just put a hands up. No personal questions will be asked. Heartbreaks. Valentine's Day के दिन, चलो let's talk of heartbreaks. How many of you have had heartbreaks in life? किनका दिल टूटा है? दिन किन लोगों का टूटा है, इंक्लूडिंग मी? चलो, किन लोगों का दिल टूटा है लाइफ में? कभी ना कभी एट सम पॉइंट ऑफ टाइम यू हैव हैड योर हार्ट बीइंग ब्रोकन. अरे शर्मा मत यार, आई एम द वन हु इज पुटिंग हिज हैंड अप फर्स्ट. जल्दी, कम ऑन. हाउ मेनी ऑफ यू हैव हैड योर हार्ट्स ब्रोकन एट सम पॉइंट ऑफ टाइम? किसी ने आपका दिल तोड़ा हो. Continuing till date. Okay, my hugs to you, dear. Somebody says आपसे एक बात पूछनी है. Okay, I will take up your question, my dear. But थोड़ी देर बाद. I'm asking किन लोगों का दिल टूटा है? किन लोगों का दिल टूटा है? So for the ones who have been heartbroken, सब शर्मा रहे आज. नहीं तो everyone is in a relationship, so they are not willing to disclose कि उन लोगों का हार्ट दिल टूटा है कभी, and I respect it. कोई बात नहीं. But do you realize जब आपका दिल टूटा था, you always kept on thinking, यार मैंने तो अपना सब कुछ दिया, I have given every bit of my love, फिर भी was my love not sufficient for you? फिर भी was my love not sufficient for you? Certificate, my dear, certificate is provided, dear. Vijay sir, are you there? Can you please attend to this doubt? Certificate is provided.
I am here.
Yeah, certificate is provided. Can we not talk of certificates right now? Because certificates are provided as much as I know. ठीक है, so let's not break the flow of this. ठीक है, मैं दिल की बात कर रहा हूँ. चलो दिल से दिल की बात करते हैं. जिन लोगों का भी दिल टूटा है, डू यू अग्री कि कभी ना कभी इन लाइफ यू हैव फेल्ट, जब दिल टूट रहा था, कि और कितना प्यार करूं, मेरे में जितना था आई हैव गिवन एवरी बिट, फिर भी इट इज नॉट सफिशिएंट फॉर हिम और हर. दिस इज केफालोपेल्विक डिस्प्रोपोर्शन. The same amount of love may be adequate for someone else, but that same amount of love is not adequate for someone else. ठीक है, मिस्टर एक्स के लिए वो प्यार काफी है, मिस्टर वाई के लिए वो प्यार काफी नहीं है. यानी कि इफ द पेल्विस डायमीटर्स आर एडिक्वेट, बट एक बड़ा बच्चा आ गया है, एक बहुत मोटा सा गोलू सा बच्चा आ गया है, अब उसके लिए दिस पेल्विस इज नॉट एडिक्वेट, राइट? तो मदर विल बी, the mother's pelvis is disproportionate to the size of the baby. That is cephalopelvic disproportion. Imagine the moments you have had your heartbreak and thought, यार क्या मैं काफी नहीं हूं? तो क्या मैं काफी नहीं हूं is what is cephalopelvic disproportion. क्योंकि आप जब किसी थेरेपिस्ट के पास जाओगे, वो बोलेंगे कि आप उनके लिए काफी नहीं हो, या वो आपके लिए काफी नहीं है, राइट? दैट इज cephalopelvic disproportion. बट इमेजिन अ पर्सन जिनको प्यार करना ही नहीं आता है, हालांकि ऐसा कोई नहीं है, बट इमेजिन से a psychopath who doesn't feel love at all, emotionally numb है, violent है, that is contracted pelvis. वो जिंदगी में किसी से प्यार नहीं कर पाएगा. With all due respect to psychopaths, वो किसी से प्यार नहीं कर पाएगा. That is contracted pelvis. But you, me, in general, our love may be insufficient for someone, but that same amount of love may be overwhelming to someone else. That is cephalopelvic disproportion. Clear? Is now the difference between contracted pelvis and CPD correct? Is this sorted? अगर बच्चा is too big in this pregnancy for the pelvis, but in subsequent pregnancies there can be a normal size बच्चा, उतना गोलू मोलू मोटा बच्चा नहीं होगा. That is cephalopelvic disproportion. यानी कि it depends on this pregnancy. It doesn't mean कि इस pregnancy में अगर CPD है, cephalopelvic disproportion है, तो अगली pregnancy में भी होगी. That's not important. We can have a CPD in this pregnancy. There may not be a CPD in the next pregnancy because the baby may be adequate for that pelvis. But if there's a universal contraction of the dimensions of the pelvis, like obstetric conjugate is less than 10, the interstitial diameter is less than 8, intertuberous diameter is less than 8, that is what we call as a contracted pelvis, which means that this pelvis is contracted forever, will be contracted forever. Clear? Is this clear with everyone? Sab clear hai? Everyone's clear with this? किसी का टूटता ही रहा है दिल 2 times. My heart goes out to you, but trust me, you will always find out the one who's waiting there for you. Trust me. Okay, so now we are done with this segment. We'll be now moving into fetal skulls. Now, when I talk of fetal skulls, no, उसका नहीं, हाँ, नीचे वाले को थोड़ा zoom करो, remove नीचे वाला. Nah, not this, parts of the skull. Yeah, zoom in that part. Yeah, great. So we'll be first dealing with a few terminologies. What do I mean by vertex? What do I mean by brow? What do I mean by face? See, this is my skull. Suppose I'm the fetus. ये मेरी anterior first fontanelle which is rhomboid, ये मेरी posterior fontanelle which is triangular. इतना clear है? Anterior first fontanelle rhomboid, posterior fontanelle triangular. Now any place which is between the anterior fontanelle and the posterior fontanelle, any place between the anterior fontanelle and the posterior fontanelle, यानी कि ये वाला part, this is what I call as the vertex. Any place in between the anterior fontanelle and the root of the nose, this is my root of nose, this anterior fontanelle, this place is what I call as the brow, brow, brow. And any place in between the root of the nose and the chin, chin is what I call as the mentum. Any place between the root of the nose and my chin, mentum, this is what I call as the face. I repeat, any place between the anterior fontanelle and the posterior fontanelle is vertex. Any place in between the anterior fontanelle and the root of nose is brow. Any place in between the root of the nose and the chin, that is mentum, is face. Is this clear? Is this clear? In a normal vaginal delivery, most commonly, we have a vertex presentation. Sorry, we have a cephalic presentation. Vertex is the presenting part, and the attitude is the baby is flexed, completely flexed or deflexed, correct? Whenever there is a partial extension, there is a brow. Whenever there is a complete extension, there is a face. That's what I had shown you previously doing my demonstrations as well. Is this clear? Now let's talk about a few things. Whenever, now what are the few points? Again, take me back to that same picture. Yeah, same picture. थोड़ा right करो, मतलब थोड़ा left करो image को. Yes, terminology. Yeah. So what is occiput? This part where my posterior fontanelle is, ये जो मेरी सबसे ऊपर, the highest point of this is what I call as the occiput. That is the occipital bone. Anything below the occiput, यहाँ पे, this is the subocciput. So this is occiput, this is subocciput. ठीक है? Mentum is chin. Submentum is below the chin, just where the face meets the neck. This is submentum. This is mentum. I repeat: occiput, subocciput, mentum, submentum. Okay, clear? Anything which is the highest point on the vertex. What was vertex? It was the place between anterior fontanelle and posterior fontanelle. इसमें सबसे highest जो point है, that is what is called as the vertical. And any point here in between the anterior fontanelle and the root of nose is what I call as the frontal. Any point on the anterior fontanelle is what I will call as bregma. I know, very confusing, but let's revise this again. Anterior fontanelle, posterior fontanelle, इनके बीच में है vertex. Anterior fontanelle, root of nose, इनके बीच में है brow. Root of nose, chin, इनके बीच में है mentum. Face. ठीक है? Now, chin is mentum. Junction between the face and the neck is submentum. This is occiput, this is subocciput. Itna clear hai? Now, any point which is at the highest point of the vertex, that is called a vertical. Any point which is on the frontal suture, matlab is jagah pe hai, that is frontal. And any point on the anterior fontanelle is called a bregma. Based on this, we have certain diameters. I do not want you to remember all the diameters. I only want you to know कि whenever a baby, normal जो हम कहते हैं, normal process of vaginal delivery, it has to be a cephalic presentation. Longitudinal lie. First is a lie, longitudinal. Cephalic presentation, यानी कि the baby's head is occupying the lower pole of the uterus. उसमें भी, if the vertex has to be the denominator or the presenting part, it has to be when the baby's head is deflexed like this. This is usually the position in which we sob, right? हम sob करते हैं ऐसे, रोते हैं इस position में. So suboccipitobregmatic diameter, SOB, suboccipitobregmatic diameter. Just see, what is suboccipito? This is subocciput. Bregma क्या है? Any point on the anterior fontanelle. So this diameter between the subocciput to the bregma, can you show it in the fetal skull diameter? The fetal skull diameter. Can you show this? Down. Yeah. Can you show the suboccipitobregmatic diameter? Yes, that is the suboccipitobregmatic diameter. That is the diameter of 9.5 centimeter that should be crossing the level of the pelvic outlet in order of, the pelvic cavity and the outlet in order to be delivered in the normal cephalic presentation with the vertex being the denominator. Clear? So that is all I want you to know. So for a completely flexed head, it is the suboccipitobregmatic diameter, that's 9.5. For a deflexed head, if this was complete flexion, this is deflection. It is the occipitofrontal diameter, occipitofrontal, suboccipitobregmatic. See, this is 9.5. This Occipitofrontal is 11.5. I only want you to remember 9.5. Yani ki if there has to be a deflex, if there has to be a fully flexed head in a cephalic presentation with vertex being the denominator, then the suboccipitobregmatic diameter has to be passing through the pelvic cavity. That diameter will be 9.5 centimeters. Okay, clear? In a deflexed head, it is occipitofrontal, that is 11.5 centimeter. When I talk about bro, it is this, where there is partial extension, and the diameter is mento-vertical. Mento is chin, vertical is here. This is mento-vertical. So this is vertex, that is the point, highest point of the between the anterior fontanelle and the posterior fontanelle. This is the vertex, and this is mentum. So this is mento-vertical, and mento-vertical is the largest diameter ever that can be possible, which means it is 14 centimeter. If you realize, हमने जितना भी diameters पढ़ा है in the maternal diameters, pelvic diameters, can you see a single diameter which is more than 13 centimeter? No. एक भी ऐसा diameter नहीं है जो 13 सेंटीमीटर से ऊपर है, which means if there's a bro presentation, what is bro? Bro is the area between the anterior fontanelle and the root of nose. कब हो सकता है? When the head is partially extended. Complete extension में face आ जाएगा, but partial extension में bro आएगा. When I talk of bro presentation, the diameter that engages is the mento-vertical diameter, which is 14 centimeter, which means it can never ever pass through a normal pelvis. So the management of any bro presentation at labor is always going to be by C-section. Okay? But that's all I want you to know about the fetal diameters. Mainly, I wanted you to focus about the fully flexed head in vertex, that is suboccipitobregmatic. Remember, sobbing करते हैं हम ऐसे, रोते, that is 9.5. और अगर थोड़ा सा deflexed head है, तो it is the 11.5 centimeter of the occipitofrontal diameter, that's 11.5. अगर bro presentation is mento-vertical, that is 14 centimeter, longest diameter, cannot pass through any size of pelvis. It will always lead to a cesarean section. Okay? When there is a fully extended head, it is face, and face has the other diameter, which is not really very important for this discussion today. Okay. Now, I already talked of contracted pelvis. Hi, Dr. Megha, good evening. I already talked of contracted pelvis. I have talked of CPD as well. But the one thing that I want to tell you, what is CPD? I am repeating. Either the fetus is too big for the pelvis or the pelvis is too small for the fetus. That is exactly what it is. Does this measurement ratta marna in exams? Yes. Ratta marna hai सिर्फ mento-vertical 14, suboccipitobregmatic 9.5, और वो true conjugate, obstetric conjugate, diagonal conjugate 11, 10.5, 12, interstitial less than 8 centimeter and intertuberous less than 8 centimeter. ये 5 याद रखनी ही है, ठीक है, कुछ नहीं कर सकते, ठीक है. It's not that difficult, trust me. TOD लिखो, TOD 11, 10.5, 12 हो गया आपका. Interstitial diameter and intertuberous diameter should be less than, अगर less than 8 है तो contracted है, अगर obstetric less than 10 है तो contracted है, हो गया आपका contracted pelvis. Now fetal skull में बच्चा sob करता है तो complete flexion में there is a vertex presentation, that is suboccipitobregmatic, sob, SOB 9.5, और ऐसा ब्रो है तो मेंटो वर्टिकल है 14 सेंटीमीटर लार्जेस्ट. दैट्स द ओनली 5 डायमीटर्स दैट यू नीड टू रिमेंबर. रट्टा तो थोड़े बहुत मारने हैं यार इस प्रोफेशन में. आप मतलब यू इवन हैव टू रिमेंबर फार्माकोलॉजी, मैकेनिज्म ऑफ एक्शन, तो थोड़े बहुत ये सब चीजें हैं which you need to remember. But I think with the advent of AI now, where I think AI will take care of the factual parts, I feel it is the need of the hour, where the ratta marne wala cheeze are taken care of AI, but the conceptual cheeze is what we deal with. But then it's going to take a really long time for that to happen. Okay, now let's focus on cephalopelvic disproportion. What is cephalopelvic disproportion? Move me to cephalopelvic disproportion, please. The next slide. Yeah. So cephalopelvic disproportion, either the fetus is too big for the pelvis or the pelvis is too small for the fetus. As I said, it is a relative finding. Your love may be sufficient for someone, but may not be sufficient for someone else. So do not be sad because it's a relative finding. The pelvis is not contracted. आपके मन contracted नहीं है. तो दिल को एकदम सुकून पहुंचाओ. बोलो कि ठीक है. If my love was not sufficient for you, okay. If I know I was honest enough, my love is sufficient for someone else. And please find that someone else. Even if you don't find that someone else, find yourself out. I think that's the best thing that you can do. So this cephalopelvic disproportion, यानी कि pelvis छोटा है, baby बड़ा है, या baby छोटा है, pelvis बड़ा है, can happen either at the level of inlet or it can happen at the level of cavity or outlet based on whatever the diameters are. What do you exactly do if you find the pelvis which is too big for the baby or a baby is too small for the pelvis, whatever it is, once you have ruled out कि contracted pelvis नहीं है, मतलब obstetric conjugate 10 से कम नहीं है, interstitial 8 से कम नहीं है, intertuberous 8 से कम नहीं है, once you have ruled the contracted pelvis out, you will now try to do a trial of labor. Let me try doing a trial of vaginal delivery, normal vaginal delivery. In fact, trial of labor has been told to be the best method for diagnosing a cephalopelvic disproportion. In case if the CPD is at the level of the cavity or the outlet, you go via the C-section. Whereas if the CPD is at the level of inlet and there is mild CPD, the baby थोड़े push करेगा, थोड़ी mother pushes a little more, okay, with uterine contractions, that CPD will be overcome. Then you do a trial of labor. But at any point of time, remember, in obstetrics, the rule is very simple. If in any trial there is fetal distress, maternal distress, or there is an arrest of labor, or at any point of time there is obstructed labor. How do you understand obstructed labor? Mother is getting tired, mother is getting hypotensive, mother is getting tachycardic, mother is getting a dry mucosa, she is dehydrated, she is exhausted, वो नहीं कर पा रही है push. That is the time when you do not say कि अपुन ही भगवान है, अपुन और कोशिश करेगा, कोशिश करने की कोई chances नहीं है, go with a cesarean section. Distress in obs is C-section. चाहे वो maternal distress हो, fetal distress हो, management is always C-section. As I said, if the baby and the pelvis are not in synchrony with each other, baby is like मैं बड़ा हूँ, pelvis is like मैं बड़ा हूँ, अगर ऐसा कुछ asynchrony है, that is CPD. CPD is only with respect to the current pregnancy, यानी कि in one pregnancy the pelvis may be adequate, but in the subsequent pregnancy the pelvis may be disproportionate to that particular child, right? This should be something that should be in your mind. Trial of labor is the best method of diagnosis. Radiologically, you can do an MRI, but trust me, nobody does it to check out CPD. Okay? Trial of labor is what you usually do. If not, NST also helps during labor to assess fetal. Yeah, NST is what will actually talk of the fetal distress. So as I said, so at any point during CPD, okay, अगर आप trial of labor कर रहे हो and any point the baby is having distress, that is shown on NST या CTG. If the mother is having distress shown on her vital parameters, exhaustion है, hypotension है, dryness है, dehydration है, anytime all of this is happening, or if there is an arrest of labor, the management is always C-section. However, if the CPD is at the level of the cavity or inlet, you can cavity or outlet, you can go with a C-section as well, because if a baby is not able to pass out through the cavity, if a baby is not able to pass through the cavity, it is very, very, very difficult that this baby is going to come out. The baby can only be tried for a trial of labor if the CPD is at the level of inlet. Inlet में अगर problem है तो थोड़े बहुत हम कोशिश कर सकते हैं, but otherwise if the CPD is at the level of the cavity or the outlet, trust me, most of the times these babies will have to be delivered via C-section. Okay, let's move ahead. Let's move ahead. Next slide, please. Yeah. Okay. Now, finally, is it time yet? So, up tak we have discovered and we have discussed what are the things that happens, what are the dimensions. Now it is the time that we first say, ये जो हमारा slide का जो session का नाम है, from the first pain to the first cry. It is important that we know whether the pain is a true labor pain or whether it is a false labor pain. I think that is the most important thing that we need to deal with. Whether this pain that is occurring, is it a true labor pain or is it a false labor pain? So, whenever I talk of true labor pain or false labor pain, there are certain differences that we need to keep in mind. And first of all, it's important to know why does the pains occur? Why does the pains occur? So whenever I talk of labor, what is basically happening is, you can put on the animation once on, Jim. Yeah, no, one more. Yes, this. So whenever the fetus has matured enough, say it is 34 weeks and beyond, or 36 weeks and beyond, when the fetus is completely matured, the fetal hypothalamus is going to release a hormone which is called the corticotropin releasing hormone, which will act on the pituitary gland, and the fetal pituitary gland will be releasing adrenocorticotropic hormone or ACTH. This acts on the fetal adrenal gland and releases an steroid which is called DHEAS. Remember, DHEAS is produced from the fetus whereas DHEA is produced from the mother. This is a very, very common confusion that is asked in your examination questions as well. DHEA is something produced by the mother. DHEAS is something produced by the fetus. So DHEAS for sulfate is produced in the placenta, which will lead to the release of estrogen, and these estrogen will be actually causing the uterine contractions. So remember, uterine contractions which start with the onset of true labor are actually due to estrogen. Now, what is the difference between true labor pain and false labor pain? A true labor pain is usually going to be regular, it's going to be rhythmic, whereas false labor pains are going to be continuous. If a woman is saying my pain is continuous, it's continuing, persistent hai, most likely it's a false labor pain. But true labor pains will be regular, it will be contractile, it will be rhythmic, and with gradual increase in time, there'll be a progressive increase in the intensity of the contractions, in the frequency of the contractions, and in the strength of the contractions. However, false labor pains often feel like a diffuse pain. They do not increase in frequency, intensity, or strength. The goal of true labor pain is to actually lead to cervical dilatation. Cervix जो बंद है उसे खुलना है. जब भी cervix खुलेगा बच्चा नीचे आएगा. Cervix खुलता है बच्चा नीचे आएगा because the uterus will be pushing now. The main aim of true labor pain is to open the cervix. So it leads to cervical dilatation, and the site of a true labor pain is usually in the lower abdomen, and it'll radiate to the back and the thigh, whereas the false labor pain will barely radiate. There are two words. One is called show. What is show? Whenever the cervix is dilating, you will find a mucus plug and blood which tends to come out. This show is actually present after a true labor pain, because true labor pain, the goal of true labor pain is to open the cervix, is to dilate the cervix, which will lead to a mucosal plug and a bit of blood coming out. That is perfectly normal, nothing to worry. It is show, and this show is what is a typical feature of true labor pain. Because the cervix is opening up, now the membranes, the amnion, the chorion, the baby's amniotic cavity is now in a relatively accessible place. So you will be able to feel the bag of membranes whenever there's a true labor pain onsetting. Now, whenever there's pain, the mother wants relief. So if you are going to give sedation, if you're going to give rest, if you're going to give enema, the true labor pains will not respond, because the reason for the true labor, not audible. Finally, someone is saying not audible. Am I really not audible?
You are audible, doctor. You are audible.
Okay, doctor, please, like leave the meeting and rejoin again. I think that'll help you. Yeah. So whenever there's sedation, where there's enema, where there's rest, the true labor pains will absolutely not subside, क्योंकि the true labor pains का काम ही है कि cervix को खोलेंगे. जब cervix खुलेगा बच्चा नीचे आएगा. ठीक है. The false labor pains, however, because they're diffuse pain, उनका कोई काम ही नहीं है. ऐसे ही है pains. So they will be responding to sedation, they will be responding to enema and rest. That is usually the difference between true labor pain and false labor pain. I've given a slide to show what is the difference between effacement and dilatation. Rimjim, can you please zoom me this part? See, dilatation is what is going to, dilatation matlab enlargement or gradual widening of the cervix. That leads to progressive descent of the fetal head with uterine contraction. What is effacement? Effacement is the shortening of the cervix. So on one end, there's a shortening and thinning of the length. So when I say effacement, I'm predominantly meaning the length of the cervix. When I'm saying dilatation, I'm predominantly leading to the width of the cervix, so the diameter of the cervix. So dilatation is diameter. ऐसे याद रख सकते हो. Dilatation, before dilatation, is the diameter of the cervix that is opening up so that the baby comes down. As the diameter increases, I don't know if you have worked with springs, कोई toy which had springs back in childhood. जैसे आप स्प्रिंग को स्ट्रेच करते हो ना, जैसे ही स्प्रिंग को स्ट्रेच करते हो, you would realize that the height of the spring actually goes down. The height of the spring goes down. So whenever there's a dilatation occurring in the cervix, there's a concomitant shortening of the length and thinning of the cervix during labor. That is called effacement. So effacement is the length being shortened and thinned out. Dilatation is the diameter that is going wider. I think that is clear. Now let's directly enter into the stages of labor. Thank you, Rimjim, for answering. So yeah, Dr. Rimjim will be answering a few questions on my behalf, the ones which I cannot be seeing due to the lack of my technical prowess here. If there's anything else after she answers and you still have a doubt, you can definitely reach out to me. But I think Dr. Rimjim is good enough to answer them. Okay, so now let's talk of the stages of labor. Now, we divide labor into a few stages. That's mainly 4 stages. When I talk of the first stage of labor, remember that the first stage of labor starts its onset from the true labor pains till the full dilatation of the cervix. What is full dilatation of cervix? It's 10 centimeters. But एकदम तुरंत ही dilate नहीं करके 10 centimeters होगा. It will gradually dilate to 5 centimeters or 6 centimeters, and then it will gradually dilate from 6 to 10. So, onset of true labor pains, as I said, the goal of true labor pains is to dilate the cervix. So when the true labor pains start happening, they will start dilating the cervix. From 0 centimeter to 5 centimeter or 6 centimeter is the latent phase of the first stage. And from 6 centimeters till 10 centimeters, which is the complete dilatation of the cervix, is what is called the active phase. So basically, we are going to divide the first stage of labor into the we are going to divide the first stage of labor into the latent phase and the active phase. Latent phase, as I said, is from the true contractions to 5 centimeter or 6 centimeter, whatever you call, and the active phase is up till 10 centimeter. Now, what is the average duration? The average duration in a primigravida is less than 12 hours. In a multigravida, it is around 8 hours. But anytime you have a duration which is more than 20 hours in a primi or more than 14 hours in a multi, that is exactly what you call as a prolonged latent phase. So what is a prolonged latent phase? It is a duration more than 20 hours in primi and more than 14 hours in multi. What is a primary gravida? जिनका पहली बार बच्चा हो रहा है. What is a multi gravida? जिनके पहले बच्चे हो चुके हैं. This is the subsequent pregnancies. ठीक है. Now, what is the cause of a prolonged latent phase? Either it is a cervix which is unripe. Okay, if the cervix is unripe, cervix is not favorable to be ripened and opened up, that is what can lead to a prolonged latent phase. The management of it, which will be administration of the prostaglandins to ripen the cervix. Okay, so we basically go with PGE1 analogs or PGE2 analogs like dinoprostone, which is available as a gel form, which helps in dilating the cervix and making the cervix ripe. Okay, or it can be an occipito-posterior position. Do you remember जब हम labor के stages पढ़ रहे थे, if the occiput is facing the sacral promontory, that is what I call as an occipito-posterior position. And I clearly said if position 1 to 5 is what can favor a normal vaginal delivery, but position 6 to 8, when the occiput is facing posteriorly, चाहे वो right occipito-posterior हो, direct occipito-posterior हो, या left occipito-posterior हो, ये तीनों positions में ही there will be a slow latent phase of labor because the contractions, the true labor pains will not be able to dilate the cervix entirely. The management of a prolonged latent phase, if you have ruled out these 3 conditions, OP position rule out कर लिया, unfavorable cervix rule out कर लिया, या फिर false labor pain, मतलब पेशेंट का जो दर्द हो रहा है वो ट्रू लेबर पेन है ही नहीं, तो अगर ट्रू लेबर पेन नहीं है तो सर्विक्स डायलेट कैसे करेगा? As I said, what is first stage of labor? From true labor pain till the full dilatation of cervix. अगर labor pain ही true नहीं है, how will it dilate the cervix? So if you have ruled these 3 out, in case it is a true labor pain, and in case it is not an OP position, it is not an unfavorable cervix or not an unripe cervix, the management is always going to be therapeutic bed rest. You will simply tell the mother to lie down and take rest. If it is an OP position, the management is usually wait and watch, because you just need to wait and watch until the baby decides to rotate and come forward. But I repeat, wait and watch in obstetrics is only until there is no fetal distress or maternal distress. हमेशा याद रखना, wait and watch doesn't work when there is distress. Distress to mother, go for C-section. Distress to baby, go for C-section. That's the usual norm. Now, unfavorable cervix is treated via prostaglandins. Now, let's come to the active phase. So from 6 centimeter till 10 centimeter, as the cervix is going to dilate, this is not just going to lead to dilatation of the cervix, but it will also cause the descent of the fetal head. क्योंकि अभी 5 centimeter के बाद जैसे ही cervix खुलने लगेगा, the uterus will start pushing the baby down. Now, we have a certain rate. The rate of dilatation of cervix for a primi is 1.2 centimeter per hour. For a multi, it is 1.5 centimeter per hour. And the descent for the fetal head in prime is 1 centimeter per hour, and for multi it is 2 centimeter per hour. इतना values याद नहीं रखना है. The basic thing which I want you to know is if there is any time there's a problem in the active phase, that is what we call as protracted or slow active phase. That means the dilatation of the cervix is less than 1 centimeter per hour. मानो at अभी कितना बज रहा है? It is 8:50. I think there's some sound somewhere. Okay, yeah. At any point of time, if there is a dilatation of cervix which is less than 1 centimeter per hour, like say abhi 8:15 baj raha hai, female's dilatation is 5 centimeter. At 12:15 in the night, you are still finding that the dilatation is say 6 centimeter. यानी कि 1 ही सेंटीमीटर बढ़ा है 4 घंटे में, जबकि 4 सेंटीमीटर होनी चाहिए. At least 1 centimeter should be dilating per hour. If at 8:15 p.m. the cervical dilatation is 6 centimeter, at 12:15 it should be 10 centimeter, at least 10 centimeter. But if the dilatation has only increased by 1 centimeter instead of 4 for the last 4 hours, अगर dilatation सिर्फ 1 centimeter बढ़ा है, that is what we call as protracted or slow active phase of labor. ठीक है. Now what do we do in that case? Move ahead. We will check for a PV examination. In PV examination, we can have 3 findings. Number 1 is a CPD, that is cephalopelvic disproportion. And I clearly told you, cephalopelvic disproportion in the current pregnancy is always a cesarean section indication. अगर ये pelvis इस बच्चे को adequately नहीं ले पाएगा, तो हम C-section करेंगे. C-section. If it is OP position, I will wait and watch. And if it is any other condition, then I will wait for the augmentation of labor to happen. Now, how do I go for augmentation of labor? अगर बच्चा का हेड नीचे आ रहा है and it has become fixed, यानी कि what do I mean by fixing of the head? Fixing of the head means it is now at the level of the ischial spine. What did I say? What was the station at the level of ischial spine? It was station 0. तो बच्चा जैसे ही नीचे आ रहा है और 0 स्टेशन पे आ गया है, the baby's head will now get fixed. अगर बच्चा का हेड फिक्स हो गया है, you will take a scissors, that's called the Kocher's forceps, the Kocher's scissors, and you will be cutting the bag of membranes. That is what we call as the artificial rupture of membranes. And after 30 minutes or half an hour, you will be giving oxytocin. I repeat, if there is cephalopelvic disproportion, go with C-section. If there is OP, wait and watch for the baby to turn. अगर इस बीच में कभी distress होता है, go with C-section. But if there is any other cause, check for uterine contractions. अगर contractions सही है, या फिर अगर contraction सही नहीं है, if the contractions are inadequate या फिर they are hypotonic, then check whether the head is fixed. If the head is fixed at station 0, go with artificial rupture of membranes and oxytocin. If the head is not fixed, then go first with oxytocin and then go for artificial rupture of membranes. Because if you do the reverse, yani ki head is not fixed, you have given ARM first and then going for oxytocin, there's a higher risk for cord prolapse. This is not written in this slide. Remember this I am telling this to you from one of my personal experiences back as an intern in my MBBS days. Whenever you find that the head is not fixed, do not give ARM first. Always go with oxytocin. Let the uterus contract. Let the head come down to station 0. Let the head get fixed. Then rupture the membranes. Otherwise, there's a high risk of cord prolapse. Okay? Now, one more thing, that is arrest of active labor or active stage of active phase of first stage of labor. What is arrest? That means that rupture of membranes have occurred, but there's no cervical dilatation. What was active phase? 5 से 10 सेंटीमीटर तक cervix को dilate करना है और बच्चा को नीचे आना है. अब मानो rupture of membranes has occurred, but cervix is yet not dilating. If the cervix has yet not dilated despite good contractions in 4 hours or inadequate contractions in 6 hours, the timeline isn't important. But 4 घंटा या 5 घंटा हो चुका है, rupture of membranes हो चुका है, but dilatation अभी भी वही के वही है. That is exactly what I call for arrest of active phase, and the arrest of active phase is usually managed via C-section. The management is usually C-section. That completes my first stage of labor. Is everyone clear with first stage of labor? Everyone clear with first stage of labor? Any doubts? It's a really difficult topic. I mean, although we all joined from 7:10, मैंने actively ये session start किया है लेना 7:20, 7:25 से. In 1 hour, I've completed almost maternal skull, fetal pelvis, basics of labor, and I've also completed the first stage of labor. I know I'm being a bit quick, but I hope I'm trying to be as interesting and catchy as I can. Okay. So for the ones who have still remained, thank you so much. And trust me, it's going to really help you. For the ones who are even preparing for your postgraduate entrance examinations, I promise you this is all you need on labor, nothing more. ठीक है. जो भी एक दो चीजें हैं, if there's someone who's preparing for your entrances, you can drop me a text here. एक या दो चीजें हैं which I'll tell you in the end, which you can add, which I've not put in this slide because it would not be able to finish the slide in 1.5 hours. But definitely the rest topics are absolutely covered up to the mark. Now, let's talk about second stage of labor. Now, when the cervix is dilated up till 10 centimeters, that's full dilatation. बच्चा नीचे आ गया है. Now, my main concern is delivery of the baby. Delivery of the baby is what is concerned in the second stage. 10 centimeters dilated cervix till the full delivery of the baby is what I call as the second stage. The average duration for a primary is 1 hour. For a multigravida, it is half an hour. increase 1 hour if you are giving epidural analgesia. I mean, there are so many patients who cannot tolerate that labor pain, and that is when we are going to give epidural analgesia. And if you're giving epidural analgesia, the average duration will increase by 1 hour. मतलब primary का average duration will become 1 + 1 2 hours. Multi का average duration will become 1.5 hours. ठीक है? What is one thing that we need to understand as a problem that can occur in this, that is a second stage arrest or a prolonged second stage. Anytime प्राइमरी में अगर 3 घंटे से ज्यादा हो गया है, सर्विक्स डायलेटेड है, बच्चा फिर भी नहीं निकल रहा है, 3 घंटे से ज्यादा हो चुका है, या मल्टीग्रेविडा में more than 2 hours हो चुका है, that is what I call as second stage arrest. Now I'll give you some scenarios and I will ask you कि आप क्या करोगे. No 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 no, बस 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 यही तक रखो. हाँ बस. Okay, I want all of your attention right here on the chat box and on my voice. Okay, tell me, full dilated cervix हो चुका है, 10 centimeters the dilation, cervix पूरा खुल चुका है, बच्चा नीचे तक तो आया है लेकिन अभी भी डिलीवर नहीं हो रहा है, but on NST you are finding there is fetal distress. What is your next step? What is your next step? हाँ, PDF will be provided, don't worry, PDF will be provided. What is your next step? I'm saying cervix is entirely dilated, बच्चा नीचे आ गया है, but बच्चा अभी तक बाहर नहीं निकला है, there is fetal distress. Yes, what is the next step? Yes, C-section, exactly. So as I told you, fetal distress in any goddamn stage is C-section unless proved otherwise. Now, fetal distress है with fully dilated cervix, what do I check? If the station is above 2 or below 2. What is zero station? It is the level of ischial spine. हमेशा याद रखना, जैसे हम ischial spine से नीचे आते हैं, that is +1, फिर नीचे आते हैं +2, फिर नीचे आते हैं +3 and finally out to the outlet. ठीक है? तो ischial spine यहाँ है, cavity, and this is the outlet. जैसे ही बच्चा का head ischial spine से नीचे आता है, that's +1, second +2, +3 and finally out. If the baby's head is above ischial spine, that is -1, -2, -3 and above. Okay? So whenever there is a second stage arrest, the first thing you check is the station of the fetus. If the fetal station is anything at +2 or below, so above +2, if it's above +2, मतलब it is +1 या 0 या उससे भी ज्यादा है, so you will directly go with C-section. ठीक है? But anytime it is below +2, यानी कि it is very close to the outlet, you will now try to do a instrumental delivery. So when I talk of instrumental delivery, there are two things. Either you can use a forceps or you can use a vacuum. There are only two indications of instrumental delivery that we have in obstetrics. The cervix has to be fully dilated, which means instrumental delivery should never be done in the first stage of labor. क्योंकि first stage of labor में तो fully dilate हो रहा है. Instrumental delivery can only be done when the cervix has completely dilated. Number one, and the station of the fetal head is below +2. +2 से नीचे है, that is when you can go for instrumental delivery. Okay? Now, often the cervix has completely dilated, but the baby is still not being able to deliver, because when I check the uterus, there are two segments of the uterus. There's an upper uterine segment and a lower uterine segment. Normally, both these segments have to contract rhythmically and synchronized way, ताकि बच्चा बाहर निकले. But sometimes what happens is, एक बदमाश सा uterus होता है, उसके वजह से क्या होता है? There is a retracted upper segment, which means that the upper segment of the uterus is tonically contracted and the lower segment is passively dilated. Imagine the upper segment contracting like this. Imagine this is the lower segment, is the upper segment. The upper segment is contracted like this and the lower segment is dilated. This is what is called as a Bandel's ring or a Bandel's ring. So presence of a Bandel's ring, or anytime you are finding that there is a molding. What is molding and what is caput? Anytime you are finding that there is a head swelling developing in the child, or there's an overlapping of the fetal skull bones, that is what is called as molding. The management is always going to be C-section. So I repeat, second stage, full dilation of cervix to the delivery of the baby. Average duration, 1 hour in a primary, half an hour in a multi. If it's more than 3 hours in a primary and more than 2 hours in a multi, that is what is cord around neck. Okay, I'll talk about cord around neck. Cord around neck is not an indication for cesarean section. बार बार बोल रहा हूँ, cord around neck is not an indication for cesarean section. You can easily take, put your fingers in, क्योंकि हम लोग भी करते थे ये, जब डिलीवरी करते थे, if I find one cord around the neck, I would just put my fingers in between the cord and the neck and take the baby out. It is possible. If you are skilled enough, you'll be able to do it. Cord around neck is not an indication for cesarean if there is no fetal distress. The moment there is fetal distress, Don't try to be Hulk. Do not try to be a Superman in any way. Just give me a moment. Hello. Sorry, I had to take the call. Yeah. So anytime you are going to have a Bandel ring, it will show that there is obstructed labor, which means the baby is unable to be delivered despite uterine contractions and a fully dilated cervix because there's an obstruction in the passage. So that is exactly the condition where you will again go for C-section. How do you understand that there is an obstructed labor? You will see the mother. The mother is exhausted. The uterus, you will be seeing that you'll be able to see the Bandel's ring. You'll be able to find that the upper uterine segment is tonically contracted. The lower uterine segment is not contracting, and that exactly will lead to the mother getting exhausted, the mother getting dehydrated, the mother becoming tachycardic. Any of these starts happening, any signs of obstructed labor, go with the C-section. Okay. Okay, that's complete second stage of labor. Let's now move into the before I move to the third stage, there are two things. Routine episiotomy is never ever to be given in second stage. I'm very sorry. There are many government hospitals. I'm very sorry. There are many government hospitals which will recommend a routine episiotomy, but routine episiotomy is not usually given in the second stage of labor. Neither is the routine fundal pressure allowed. Suprapubic pressure can be given in certain moments, but fundal pressure is not allowed in the second stage of labor because that will lead to a rupture of the uterus. There are so many cases where excessive fundal pressure has led to rupture of the uterus. So that is something which you should completely avoid. What is used rather as a prophylactic measure in cases of the second stage of labor is what we call as a modified Ritgen's maneuver. Basically, this is the time jab bacha bahar nikal raha hai, right? So the baby is coming out. I need to protect the perineum. So the mother's perineum is what I need to protect. So one hand will be on the perineum. I can use a warm compression or a warm compressive heat on the perineum to lax the muscles. But one hand will be on the perineum. The other hand will exactly be on the abdomen. When the baby starts delivering, I will first flex the baby's head and then take it out by extension. I'll flex the baby's head, take it out by extension, giving a support to the perineum, a warm compressive support to the perineum. That is exactly what is modified Ritgen's maneuver. That completes our second stage of labor. This is the labor stage where I need to be concerned with the successful delivery of the fetus. At any point, if I have obstruction, I will go with C-section. Any point I have molding caput, I'll go with C-section. If not, if there is no obstructed labor, the station is below +2, it is easier for me to take out, go with instrumental delivery. If the station is above +2, go with C-section. That is the sum up short in of the second stage of labor. Now, we quickly move to the cardinal movements of or the cardinal stages of labor. We have a YouTube shorts for this. So this shorts is going to explain me what is going to happen. I'll tell Rimjim to be absolutely slow with this because that will actually help me to explain each stage. So let's move to the cardinal movements of labor. Yeah. So first, there's an engage. You can mute the video. You can mute the video absolutely. Yeah. Yeah. Can we start from the beginning? Can we start from the beginning? Can we start from the beginning? Yes. Yes. Perfect. Perfect. So first you see that the baby has entered from the inlet. It has crossed the diameters of the inlet. And now exactly you can see the baby's head is at the level of the ischial spine. I told you baby's head is level at the level of ischial spine means the baby is now at the level of the plane of least pelvic dimension. The interischial diameter is 8 centimeter. Baby's head has engaged. This is what I mean by the baby's head being fixed or the baby's head being engaged. So the first step or the cardinal level or the cardinal movement of labor is what I call as engagement. So engagement is nothing but the baby's head fixing at the level of the ischial spine. Now, whenever I'm talking of labor, I'm predominantly this labor that I'm showing you. This labor is where the baby has started from left occipito transverse. No, Rimjim, we do not need to move ahead now. Go slow. You can see that the baby's occiput, can you see the baby's occiput? It is facing the mother's left side and is transversely placed. That is position 1 from where we started. As I said, position 1 to 5 favors a normal vaginal delivery. So this is left occipito transverse position. Now we'll be seeing what happens. The first step was engagement. What is engagement? The baby's fetal skull diameters have reached at the level of the ischial spines and has now been fixed. Now, let's move gradually. Whenever the fetal head is engaged, the uterus will start its contractions. That will lead to descent. But pause, yeah. Whenever the uterus has contracted, it will lead to descent. Now, baby's head will descend. There's a hook or a hammock-like muscle called the levator ani, which is located at the level of the least pelvic dimensions. Whenever the baby's head will hit this hammock, it will bounce up. So, engagement, descent. And whenever there's a descent that is occurring, the baby's head will hit the levator ani muscle, and just see the movement of my head. This is the levator ani hitting, and the baby's head is getting flexed. The baby's head is getting flexed. So, engagement, descent, hitting the levator ani, following it, there is flexion. Play the video now, please. Please play the video now. Yes, so that is the flexion that we'll be seeing right now. Can you see? Yes, that is the flexion that is occurring. This flexion that is occurring, check for it again. The flexion that is occurring, this flexion is predominantly due to the contraction of the levator ani muscle. Whenever there's a flexion, now clearly understand, we had already talked about it. Right now, the presentation, the lie is longitudinal, the presentation is cephalic, the presenting part is now the vertex. And this is going to happen with a completely flexed head. What was the diameter of the fetal skull that crosses at the level of this point? This is the suboccipitobregmatic diameter, or the 9.5 centimeter diameter that has to cross. I said the fetus is now having a completely flexed head. It looks like the fetus is sobbing. So SOB, sob, is suboccipitobregmatic diameter, that is 9.5 centimeter diameter, that has to cross through the cavity and allow for the delivery. So first was engagement, then is descent, then is flexion. At this point of time, whenever the head has flexed, you will start finding that upon flexion, yes, but keep it paused there. No. Just thoda sa piche lao. Yes, correct. At this point, you will be clearly seeing that the occiput has moved anteriorly from being into a transverse position into a direct occipito-anterior position. जब हमने labor शुरू किया था इस बच्चे में, you can clearly see that the occiput was facing the pubic rami. It was in the left occipito-transverse position. जब ये बच्चा नीचे आया है, now when the head flexion occurs, this has completely moved the head via 2/8 of a circle, that is by 90 degrees. Head has rotated by 90 degrees, and this is the time when the head has now moved from being a left occipito-transverse into a left occipito-anterior position, or a direct occipito-anterior position. You know this, if I have to deliver the baby, the occiput should be at the level of the pubic symphysis. So, पहले बच्चा का head ऐसा था, the occiput was here. Now the occiput is facing the pubic symphysis. If the camera is a pubic symphysis, this is where the occiput was earlier. It has now been facing like this. So earlier my head was here. Now it's here. It has turned by 90 degrees, right? When the head has turned by 90 degrees, do you realize this is what I call as internal rotation of the head? But the head turning by 90 degrees. Now look at me clearly. This is my plane. My head was like this. I moved 90 degrees. Not just did my head turn, but my shoulder also moved. Now, earlier, जब head turn नहीं हुआ था, when the head had not turned, so earlier I was like this, my shoulder was directly facing the pubic symphysis. It was in a very favorable position to get delivered. When my head has turned by 90 degrees and my shoulder has also turned, my head has come into a favorable position, but my shoulder is in an unfavorable position for delivery now. Can you all understand? Can I have the chat box active? The camera is the pubic symphysis. यहाँ से delivery होगी. I started in a left occipito-transverse. I moved like this, and there was a 90-degree movement of my head, which also caused a 90-degree movement of my shoulder. At this point of time, earlier, when I was like this, my shoulder was in a favorable position for delivery. Now, when my head has come, the shoulder has rotated, head is in a favorable position, but the shoulder has gone back to an unfavorable position. This is the time when there's a fight between the fetal head and the fetal shoulder. Head shoulder को बोलता है कि तुम यहाँ आ जाओ. The shoulder is like, if you are the one who turned, how can I come back like this? So the fetal head says, ठीक है, let me do something. Let me turn my head like this and try making sure that there is a 90-degree angle that is maintained between the head and the shoulder. But when the fetal head tries to turn, there's a torsion that appears on the neck. You can clearly see when trying to turn, there's a torsion that is developing on the neck. Now, this is a problem that can be overcome in a different way. How? So I'm repeating. हमने LOT से शुरू किया. Shoulder was in a favorable position. Head turned by 90. Shoulder turned like this. Shoulder unfavorable. Head favorable. Head says to shoulder, "Tu yahan aaja." Shoulder is like, "I can't come." Head is like, "I cannot go there." Now, head tries to turn like this, causing some torsion in the neck. At this point, nature devises one of the best methods that is called restitution and crowning. What exactly happens? See, head has to turn by 90 to make shoulders favorable, or the shoulder has to turn by 90, making the head favorable. So both head and shoulder decides बीच का रास्ता पकड़ते हैं. Let each of us turn by 45 degree. So the head turns by 45 and the shoulder turns by 45. So there is an external rotation of the head followed by an internal rotation of the shoulder. That is exactly what will be demonstrated in the video right now. Please play the video. You can clearly see. नहीं, थोड़ा 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 पीछे से जाओ, थोड़ा पीछे से जाओ, थोड़ा पीछे से जाओ. Rewind, 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 rewind. थोड़ा एकदम शुरू से करो तो एकदम शुरू से करो. Yeah, let's follow it step by step. This engagement, this descent, this flexion. When there's flexion, now exactly you will see this is the moment when the flexion is happening. Please see how the shoulders will rotate. Yes, this is exactly when the shoulders have rotated and become unfavorable. Now the shoulders are in an unfavorable position. The head is in a very favorable position for delivery. Now, at this point of time, the shoulder and the head both will move 45 degree. The head will move outwards by 45. The shoulder rotates inward by 45, thereby making the delivery possible. Please play the video now. This, and finally, the baby's head is delivered via extension. So, again, repeating the steps, there's engagement, there's a descent of the fetal head. Following the descent, it hits the levator and eye muscle, leading to flexion of the fetal head. The flexion of the fetal head will lead to an internal rotation. As I said, there'll be an internal rotation of the occiput. It will rotate by 2/8 of the circle, 2/8 of a circle, to come in a favorable position at the pubic symphysis. Now, this is a favorable position for the head. However, the neck is under torsion. Because the neck is under torsion, it will gradually try to untwist itself by externally rotating 45, and the shoulders will come in the anterior plane by a rotation internally, occurring by 45 degrees. So the head undergoes external rotation, the shoulders undergo an internal rotation, following which the head is delivered via extension. That is what are the cardinal movements of labor. And that is the best possible way by which I could show you. You can take out a pelvis. I mean, you can go to any एक plaster of Paris या फिर कोई भी models बनाता है अभी pelvis का. You can take a pelvis, you can take a dummy doll, and you can try doing these movements. These will be extremely clear. You can also go to this link for the YouTube shorts, and you can look at the video as well. That's the best possible way. But these are the steps. The way that I would actually try to. There's no mnemonic to remember this, to be honest. But I'd still tell you that you first engage. When you engage with a person, you get down on your knees to propose that lady. So there's a descent. Then you actually flex your neck and say, "Will you please marry me?" So there's flexion. The following rotations are very simple. It's internal rotation, then extension, restitution, and external rotation. And the head is ultimately going to be delivered via extension. You can just remember it that way. But I'd still prefer you to remember the concepts and help see the shots so that the concepts become crisp and clear in your head. So let's move ahead. We'll move ahead now to the third stage of labor. And the third stage of labor, when I talk of the third stage of labor is actually concerned with basically, now that the baby has been delivered, I need to now take care of the placenta. So I need to find the stage between the delivery of the child or the fetus to the delivery of the placenta. This is the stage which leads to maximum complications, the most predominant complications being postpartum hemorrhage. There are also other complications like collapse or amniotic fluid embolism, which is out of the scope for discussion today. So we'll be rather focusing on the active management of third stage labor, which is the WHO guideline. And at this juncture, I'll be calling in my colleague, Dr. Rimjim, to speak about AMTSL guidelines. So, Rimjim, if you can please take over AMTSL, following which I'll be talking of PPH, and we'll be winding up the slides today. So that's Dr. Rimjim for you, and she'll be taking you through the active management of the third stage of labor. Go ahead, Rimjim.
Good evening, everybody. Am I audible?
Yeah, you're audible now.
Thank you, Dr. Navonil Dutta and the team Mediversal for allowing me to speak on this matter. So let's talk about the third stage of labor. Up till now, we have done that the first stage of labor consists from the uh, true labor pain onset till the 10 centimeter dilation. From the second stage of labor consists of the 10 centimeter dilation to the delivery of the baby. And now the third stage of labor occurs where from the delivery of the baby, we need to deliver the placenta. If placenta is not delivered, it will further increase the risk of infection. It will cause it will cause continuous bleeding. You must have seen the deliveries happening, no, that after a delivery has happened, there is a lot of blood that has been spilled in that container and everywhere. बहुत blood होता है basically. So we need to stop that blood, okay? Because अगर blood stop नहीं करेंगे तो patient hypovolemic shock में चला जाएगा. So that's why we need this particular stage mein hi we usually do active management of third stage of labor. Why? Because we need to stop the blood, we need to coagulate the blood. Okay, wait. So active management is done to the for prevention of the postpartum hemorrhage. What is postpartum hemorrhage? When the baby is delivered, if the blood has not been stopped due to the due to the hypovolemic shock, we tell that we tell the term to be as postpartum hemorrhage. Okay. Uh, the average duration of the third stage of labor should be done within 5 to 10 minutes. You see, up till now the latent stage was approximately at 8 hours, the first stage was approximately at 1 hour, but the active management of third stage of labor should be done by 5 to 10 minutes, and maximum it could be stretched till 30 minutes only. Okay. Now, coming to this active management of third stage of labor, there are 4 steps which are WHO recognized, and it should be followed by everyone who is helping the baby deliver. First of all, we need to administer the uterotonics. Okay, usually oxytocin is the preferred uterotonic. Uterotonic means it will constrict the uterus so that there is no more bleeding happening. Okay, it will cause vasoconstriction as well. So the first choice is oxytocin, which is administered 10 international units intramuscularly. There are various other uterotonics also available in case oxytocin is not there. Oxytocin is usually not there if there is the cold chain of the oxytocin is not maintained. Okay, so here are the list of other few uterotonics that can be used. The doses are important for the PG entrance point of view, so you can go through this. The second step is the delayed cord clamping. Now, this is more for the baby rather than for the mother. We do the delayed cord clamping so that the blood present in the cord gets to the baby, and so the baby does not end up in anemia. Okay, so delayed cord clamping is done like whenever baby gets delivered, within 1 minute of the baby getting delivered, we do the delayed cord clamping. When can we do early cord clamping? So can anyone tell if when early cord clamping is advised? Can we have chat box open? Okay, so there's a question that how much blood loss that we consider PPH during delivery. Management of PPH is coming in the upcoming slides, but to answer your doubt, we usually consider 500 ml for vaginal delivery, 1000 ml for C-section, and in case of more than 300 ml blood loss with any changes in vital signs like hypovolemia, tachycardia, shock symptoms, etc. So that is why that's when PPH is considered. Fetus registration needed. Yes, exactly. Early cord clamping is only recommended if there is a non-vigorous baby. The baby is not active, hence that would indicate to do the neonatal resuscitation. We need to activate the neonatal resuscitation program. And in case of birth asphyxia, only these two conditions are the absolute indication of early cord clamping, where we, instead of waiting for the blood to flow from the cord to the baby, we in fact milk it. We milk so that the blood from the cord gets to the baby, and then we cut the clamp, and then we cut the cord. Okay. Coming to the third step, No, Rh negative patient is not the absolute indication. Rh negative is the relative indication. It is not generally followed, but we would definitely go to the absolute indication of the early cord clamping. Okay, Rh negative is not usually considered now, and even in MCQ criteria, if you are solving MCQs, you would not mark Rh negative patients in that case. Okay. Coming to the control cord traction, now the third step, the control cord traction of the placenta. That's where we very carefully try to remove the placenta from the uterus. Okay, so we the say this is the scissor from which this is the clamp from which we have tied up the cord. We twist it. We also give the suprapubic pressure. Okay, we also do the suprapubic pressure so that there is no uterus inversion happening. We twist it, we gradually pull, and the direction of the pulling, as you can see, the direction of pull is downwards. Okay, here you can see a suprapubic pressure is being applied and the direction of pull is downward. So we twist, we also apply the suprapubic pressure, and gradually, very slowly, we do not need to rush. If we rush it, the cord would get broken, or the cord would get broken and the placenta would remain inside. So that is another complication. We do not need to rush. Okay, we very gradually twist it, keep on twisting it, so that the placenta gradually comes out. And also we apply the suprapubic pressure so that the uterus does not come along with the placenta. We need the uterus to stay there. Okay. And lastly, we have the intermittent assessment of uterine tone after delivering the placenta. We assess the uterus. If the uterus is still contracting, we need the uterus to still contract so that the blood gets stopped, so that the blood remains like the vasoconstriction happen over there, and there is less amount of blood loss happening. Okay. Certificates will be provided by the Mediversal team. Let's not talk about the certificates right now.
Okay.
What is not done is the uterus massage. Uterus massage was previously a part of the active management of third stage of labor, but now uterus massage is not contraindicated. It's not no more being followed. So let's summarize the 4 steps of active management of third stage labor real quick. First of all, administer uterotonic. The first choice is oxytocin 10 international units IM. Okay, again, oxytocin is never given intravenously. It would lead to hypertension, sudden hypertension. Okay, delayed cord clamping. Only place where early cord clamping is indicated is when fetal resuscitation is required, i.e., if it is a non-vigorous baby or there is a case of birth asphyxia. Control cord traction. Okay, I forgot telling you this, the maneuver which I talked about, the suprapubic pressure along with the control cord traction, that is called the Brand Andrews maneuver. I repeat, Brand Andrews maneuver. Okay, this won't allow the uterus inversion to happen, and also it will cause a successful delivery of the placenta. And lastly, we have the intermittent assessment of uterine tone. Every 15 minutes, we check if the uterus is still contracting. We need the uterus to still contract even after the delivery of baby and the delivery of placenta. Okay. Am I clear, everybody? Shall I move to next slide? Okay. Thank you, Dr. Twinkle. Thank you. Okay. Coming to the third stage of labor. Okay, let's talk about the signs of placental separation. Okay, हमने यहाँ पे किया था that in the control cord traction we twist and we apply the suprapubic pressure. We also try to pull it, right? So what are the exactly signs of placental separation? How do we know that placenta is separated? We are not having a USG. We do not do live USG. We do not do live MRI to know if the placenta is really separated. Okay, we need a clinical signs to know if if the placenta is separated from the uterus. So what we first get a suprapubic bulge. Let me just show you. So if you are able to see my pointer, yeah, this is the placenta, and here we can feel the suprapubic bulge. Suprapubic bulge is felt above the pubic symphysis. Okay, so this is the suprapubic bulge where we'll feel, because after the baby is delivered, the uterus size is uterus has relatively shrunken, and hence we'll feel the placenta over here. Okay, the next sign is the uterus becomes firm and globular. Okay, there is a sudden gush of blood. Remember this. Okay, so what is exactly placenta? Placenta is the connection between the maternal vascular system and the fetus vascular system, right? So behind, like, the placenta is like uterus is connected to placenta is connected to the baby. That's how the structure of, that's how we draw, that's how the general structure is: uterus, placenta, and the baby. So if you try to extract the placenta, behind placenta there is actually a retroplacental blood present. So if you try to extract placenta, that retroplacental blood gets free, and you will see blood, like a sudden gush of blood coming from the introitus. There is apparent lengthening of umbilical cord. Of course, if you pull a cord, you will see that, you can see that there is apparent lengthening of umbilical cord. The length of the cord gets lengthened. It is not actual lengthening of cord. Please note, it is apparent, because more than half of the cord was present inside the uterus, and when you try to pull it, it comes out. So that is apparent lengthening of cord. This is the most reliable sign of placental separation. Okay, now coming to this Duncan and Schultz method of placental separation. Duncan and Schultz. So there are two methods of placental separation. Okay, in Duncan, the maternal side of the placenta gets separated first. You will see maternal side of the placenta getting delivered first. Usually, again, let's go back to this. What do we have? We have a uterus, we have a placenta say umbilical cord, and then we have a baby. So ideally, if the baby is delivered, and if you pull the placenta, the first fetal side of the placenta should be wait huh? fetus side of the placenta should be delivered. Okay, so fetus side of the placenta is usually shiny. Okay, so fetus side of the placenta is usually shiny, and that's what gets delivered first. This is the most common method of delivering the placenta, which in where the fetal side of the placenta gets delivered first. So fetals, shiny, Schultz. Coming to the maternal side of the maternal side of the placenta being delivered first, that is named as Duncan's method. Okay. This is now coming to a complication of third stage of labor apart from PPH. How much time to take for separate placenta after delivery of baby? I told you. Wait. Here we have written the average duration of what you're talking about is the third stage of labor. The third stage of labor should be done by 5 to 10 minutes, and maximum it can go till 30 minutes. Okay. Yeah. Coming to the complication of third stage of labor, the first complication is that even after 30 minutes, you find that the placenta is not being delivered. What can be the possibilities? Okay, so even after 30 minutes, if the placenta is not delivered, we term it as retained placenta or prolonged third stage. अब तक हमने सभी में ही देखा कि सभी में prolonged latent phase था, prolonged first stage था, तो अभी prolonged third stage भी है, of course. So this is called as retained placenta. Then we'll check for if the signs of placental separation is present. Placental separation just means that placenta has been separated from uterus. The placenta, even after separating from the uterus, it can remain inside the uterus. It has not yet come out. Placenta can still remain in the uterus. Okay. So signs of placental separation, if it is present, then that is termed as the trapped placenta. Okay. So what is exactly trapped placenta? The placenta has separated from the uterus, but the placenta is still there inside the uterus. We need that placenta out. For that, what shall we do? We'll again administer oxytocin, and we'll again do the control contraction, the same method. Okay. अगर ये नहीं हुआ, if this even after doing control contraction, you are still finding कि the uterus is not the placenta is not coming out, then you will do manual removal of placenta. MRP is manual removal of placenta. Okay, you will actually the obstetrician would actually put all of the fingers, the whole hand inside the uterus, and try to remove the placenta by hand. So that is manual removal of placenta. An important thing to note over here is before doing manual removal of placenta, you need to administer antibiotics. Otherwise, antibiotics is not indicated in active management of third stage of labor. Only if you're doing manual removal of placenta, you need to administer antibiotics, because uh, you're actually putting inside a foreign body. Your hand is a foreign body. If signs of separation is not present, that will be termed as that the placenta is still attached to the uterus. So placenta is still attached to the uterus. You're not seeing the lengthening of cord. You're not seeing any gush of blood. You're not seeing any suprapubic bulge. So in that case, that means that the placenta is still attached to the uterus. So then we will check for if myometrium invasion is present or not. That is checked by USG. Myometrium invasion is checked by USG. Okay. If myometrium invasion is absent, that means it's a good to go. That means that placenta is just not separated. Myometrium invasion is not there. So all you need to do is again give oxytocin, give a trial of controlled contraction. Agar nahi hua, do manual removal of placenta. You actually scoop out the placenta in this case. Okay. If myometrium invasion is present, so anyone can guess if myometrium invasion is present, what that terminology would be? I'm seeing the chat box. Type it out fast. Okay, I don't think so. Koi baat nahi. So if myometrium invasion is present, we term it as placenta accreta spectrum. Has anyone heard about this terminology before? I think you guys might have. If you have been answering till now, you must have, of course, heard about this placenta accreta spectrum. What happens in placenta accreta? Placenta accreta spectrum is where the placenta is so attached to the uterus that it is not like, usually placenta should be attached only to the endometrium layer. We talk about the decidua bassalis, decidua parietalis, and decidua capitis, right? That is, so decidua bassalis is the layer where placenta should be attached. But in cases of myometrium invasion, the placenta has crossed endometrium, and it is in fact attaching to the myometrium directly. Okay, so that is what is called as placenta accreta spectrum. There are further 3 types of placenta accreta spectrum. You will read it in, like, that's a further deep knowledge than this. But any type of placenta accreta spectrum, any type of placenta accreta spectrum, what we'll do is directly do a hysterectomy. We would not try to do manual removal of placenta, because it would cause even more blood loss. We would not do all of that. We'll directly do, unfortunately, for patients with placenta accreta spectrum, we would directly go with hysterectomy. The mother could not bear any further child. You can see this is the specimen. Here there has been a C-section done, and this is the uterus. Okay, this is the uterus. Here you can see a C-section has been done. Unfortunately, maybe it was found that the mother is suffering from the placenta accreta spectrum. Hence, the whole uterus is now being removed. That is called as hysterectomy. I guess this is all I had to say. If there is any doubt.
Okay, there's one question that was posted. That is, what is whether Rh negative pregnancy is a contraindication for delayed cord clamping or not? The answer is, in Rh negative pregnancy, we are continuously monitoring the patient. So if at all at some point of time the peak systolic velocity crosses 1.5 millions of median, that is 1.5 MOM, that indicates severe fetal anemia. Whenever there is severe fetal anemia, that is the case that when we will be going for a delayed cord clamping. Otherwise, we will be going for early cord clamping. That is why I said that, she said very rightfully that Rh negative pregnancy is a relative contraindication. It is not a complete contraindication. The only times we will indicate an early cord clamping in India, at least. Why I'm saying, because the American guidelines are different. The American guidelines say that even for an HIV positive mother, we will be going for an early cord clamping. However, in India, we do not follow that. We do an HIV positive mothers, maybe we are going to do a delayed cord clamping. The only time that we'll be going for an early cord clamping is when the baby needs resuscitation at the earliest. So if the baby is asphyxic, if there's a poor cry or no cry, or a weak cry, that is exactly when we know that the neonatal resuscitation protocol has to be initiated. And that is exactly when we will be going with the early cord clamping. And what do I mean by early cord clamping? It is a clamping that is done within 1 minute, that is 60 seconds. Delayed cord clamping का मतलब है कि 2 से 3 मिनट तक I allow the cord blood to move into the fetus, thereby reduction of chances of fetal anemia, reduction of chances of intraventricular hemorrhage, reduction in chances of even a potent complication called necrotizing enterocolitis has also been found due to delayed cord clamping. Let's now gradually move to the next slide. In fact, I think that's the penultimate slide that we have. The next slide, please. Yes, that's postpartum hemorrhage. As I said, this is the only complication that we'll be talking about in third stage, despite there being two others, that is uterine inversion and amniotic fluid embolism, which we'll be not covering. So for the ones who are preparing for the entrances, I'll tell you that you can go with studying those two topics. Okay, there's a question that has come from Dr. Gautam. How to manage shock in the fourth stage. We will be going with that. We will be going with it. Do not worry. So now let's focus on the third stage first. In third stage, one of the most important complications, and in fact, WHO has taken a very strict guideline where it puts on the rules for managing an obstetric emergency which is coming with PPH. So the first step, what is PPH? Anytime there's a loss more than 500 ml in a vaginal delivery or more than 1 liter in C-section, or at any point of time 300 ml of blood has been lost in a moment with the vital parameters reduction, which the mean arterial pressure is reducing. The shock index. What is shock index? It's a very important parameter. It's heart rate by mean arterial pressure. Anytime the shock index is below 0.7, you should start realizing that this patient is going to go into an impending shock. What shock is most common during postpartum hemorrhage? It is hypovolemic shock. What is the most common shock that is seen in uterine inversion? It is neurogenic shock. So what is the first thing? The first step is to resuscitate. So the most common cause is mainly going to be because of a uterus which is not able to contract. So a uterus which is not able to contract will not be able to cause vasoconstriction. There will be less release of PGF2 alpha, and that will not cause vasoconstriction, thereby leading to the gush of bleeding that will be occurring. So the first step is to resuscitate. And when I say resuscitate, it is you call for help. You insert large bore cannulas. When I say large bore cannulas, preferably gray or green. In most centers, we do not have gray. So we settle for the green, which is the 18 gauge cannula. The gray is the 16 gauge cannula, as all of you might know. So we insert 2 large bore IV cannulas. You collect the blood samples for ABO blood grouping or RH typing. You do the basic blood investigations like CBC. You check for the coagulability parameters, the bleeding time, the clotting time, and you arrange for blood. In the while that you're arranging for blood, you need to replace the lost volume. So the lost volume is what you replace by crystalloids. Most likely you go with lactate, or if lactate is not available, you go for normal saline. Lactate is something that is usually preferred because it is the most consistent with the human plasma. So 1 liter of crystalloids is what we infuse. We take into consideration the management of the ABCs, that is a general emergency management procedure, airway, breathing, and circulation monitoring. You insert a Foley's catheter because Foley's catheter insertion helps you monitor the urine output, and urine output is the most reliable marker for improvement of shock in these cases. So yes, it's a tennis ball-like consistency. There's a flaccid uterus that might lead to postpartum hemorrhage. Whenever all of these basic resuscitation measures have been taken, you go for a per abdominal uterine massage. Now remember, AMTSL was strictly saying that uterine massage is not to be done. Uterine massage is not a part of AMTSL, it is a part of PPH. So it is basically done when hemorrhage is happening. In AMTSL, it was intermittent assessment of the uterine tone to find whether the tonicity of the uterus is being maintained, right? Whenever there is a good tonicity of uterus, you do not need to go for uterine massage. But in this case of PPH, where there's severe hemorrhage occurring, the patient is going into shock, the vitals are deranged, this is the time when you need to give a uterine massage so that you're able to create a certain compression that is going to lead to vasoconstriction. Now, if the uterus tone is reduced, which is most commonly, the case of atony, which is maintained by massage, which indicates atonic PPH, and that is exactly when you will start to do a PV examination to rule out whether there is some retained, parts of placenta which are there inside. You will start infusing injection tranexamic acid, and the first and the most important step that you give in this case is the administration of a uterotonic, most likely oxytocin, because oxytocin is what we will be giving. As Dr. Imjim clearly said earlier, you should never give it IV bolus because it will lead to hypotension. You will rather give it in the form of IM or diluting it with normal saline. 10 international units is what you start with. You give oxytocin, and unlike AMTSL, where you just give 10 international units of oxytocin, here you give almost 20 to 40 international units of oxytocin. infusion is continued, and gradually you will start finding that oxytocin, being a nonapeptide and being an PGF2 alpha releaser from the decidua basalis, it will start to cause vasoconstriction. In cases you are not having oxytocin, you can then go with something which is called methargin or methylergometrin. But please be careful of using methylergometrin in patients who are hypertensive. It can lead to a rebound hypertension in these patients. You can also use certain other drugs like carboprost or misoprostol. The doses and the drugs were discussed already in the last slide. So I'm typically going to now talk about the management of atonic PPH, where you have given resuscitation, you've given tranexamic acid, you have started arranging for blood products, you've given your utrotonic, be it oxytocin, be it methylargometrin, whatever it is. If you give oxytocin, if the patient is still unresponsive, you go with methylargometrin. If the patient is still unresponsive, you go with carboprost, or you can even add misoprostol as an add-on drug to it. But suppose all of these measures have failed, you will now start to do mechanical compression. What is mechanical compression? You'll be either using a Bakri balloon catheter. That's the most common thing that is used in India. You basically inflate a condom catheter or a Foley's catheter, and you try to use that compression of the inflated Foley's catheter or the condom catheter on the walls of the uterus. The usual capacity of this catheter is around 500 ml. So it will try to seal the blood losses areas. In a bigger setting, you can use something like a sense taken Backmore tube, which is something used in the management of UGI bleed. But most centers in India are not having SB tubes, so you can just trust the condom catheter. If the patient is, responding to it, if the patient is going good, you remove the catheter after 12 to 24 hours. But suppose the patient is not yet responding, the vitals are unstable still, then this is the time when you should think of shifting the patient to the OT gradually to do a uterine artery ligation. So uterine artery ligation is what you start thinking of when this patient has not responded to the mechanical compression. And in uterine artery ligation, you'll have to shift the patient to the OT. You will have to do an external iliac artery compression as well. And later, you'll be having to apply the compression sutures. The most common compression sutures that we use are the B-lin sutures or the B-brace sutures, as they may be commonly called. So you'll be using those sutures, and they'll be acting as a compression. Suppose, in spite of all of these measures, the bleeding still continues. This is where you need an interventional radiologist. You will need a radiology intervention where you will start to try and embolize the uterine artery. So either you will be embolizing the uterine artery, or you'll be devascularizing the entire vasculature of the uterus. You'll start with a unilateral uterine artery ligation, followed by a bilateral uterine artery ligation. And if still the bleeding is happening, you have to ligate the bigger branches like the ovarian artery or the anterior division of the internal iliac artery. So basically, the method is simple: resuscitate, maintain ABC, maintain blood products, give utrotonics. Oxytocin fails, give ergometrin. Ergometrin fails, go for carboprost. You can add misoprostol. Still not happening, go for compression with Bakri balloon or condom catheters. Still not happening, go for the uterine artery ligations. Still not happening, go for a radioembolization first of the uterine artery, both sides uterine artery. Still not happening, still the PPH is continuing, go for the ligation of the ovarian artery. And finally, if nothing is working out, go for the anterior division of the internal iliac artery. In spite of it, if nothing is happening, you have to finally go for a subtotal hysterectomy, and unfortunately, the mother will not be able to bear any more child in her subsequent pregnancies. So that is exactly what is the management of PPH. PPH management is something which is extremely important. The drugs, the doses, the route of administration, and the side effects, particularly like carboprost, should be avoided in people who are asthmatics. Methylergometrin should be avoided in patients who are hypertensive and having heart disease. These are things you need to take care of, and they have been dealt with in the previous slide. The doses and everything has been mentioned. So I'm not going to talk of it. We'll move to the next slide. This is the last stage of labor. That's the fourth stage. This is basically nothing but observation after delivery of the placenta. Usually the patient will be fine, might experience some physiological chills, nothing to worry. If at all the temperature is going above 100, that is when you need to think about some postpartum infections. But most of the time, these patients usually stay well. What you need to be doing is checking the uterine tone after every 15 minutes. Vitals should be checked very regularly. And you have certain secretions from the introitus, which is called lochia. And that's exactly the time when we put the female on pads, and we inspect the pads for the change in color. There are mainly three kinds of lochia that we find. Lochia is nothing but the discharge that we get. We call it by RSNA, that is Republic of South Africa. That's Lucia rubra, which is red, serosa, which is kind of brownish, and alba, which is the whitish yellowish discharge which comes. By the 21st day, the discharge starts going down, and usually this is very physiological. Nothing to worry at any point of time. If there's foul smell or there's association with maternal tachycardia or fever, should you start thinking about infections. Someone asked about shock, but I'm so sorry. I cannot be discussing about shock in this segment, at least, because majorly we were talking about the normal labor and some associated complications, but maybe sometime else we will be talking about management of shock in the later stages of labor. Mainly, I can only tell you two things. Shock in the fourth stage of labor or shock after third stage of labor can be predominantly due to three reasons. One is PPH, which will lead to a hypovolemic shock. One is amniotic fluid embolism, which will lead to DIC. And this DIC will be so bad, it will literally kill the patient in minutes. I have had at least 3 cases of amniotic fluid embolism till now in my life. All the 3 patients, unfortunately, succumbed. And the last can be uterine inversion, which will lead to a neurogenic shock. So that's the maximum about shock that I can discuss till now. The final slide is a question for all of you, and I want you all to participate in this question. Can you please zoom this? Can you please zoom this up? Yes. So this is the question where a 24-year-old primey at 39 plus 2 weeks is in labor. She has been in the second stage for 45 minutes. So she's a primey. She has been in second stage for 45 minutes. Cervix is dilated, membranes are ruptured, uterine contractions look good. Fetal heart rate normally should be between 110 to 160. So this time it's 150. Looks good, but now there is recurrent late decelerations with slow recovery. Recurrent late decelerations are a sign of fetal distress. Usually it's a sign of uteroplacental insufficiency, which means that the fetus is now becoming compromised. The fetal perfusion is now being compromised. There's no fever, no maternal fever, rules out any infection in the mother, rules out any chorioamnionitis. No oxytocin infusion has been yet done. On per vaginal, the station is +2, which means it's almost close to the outlet. Occipito anterior is a position you find caput and molding. Again, whenever you find caput, you find molding, you will have to understand that there is a case of arrest of labor happening. Now, this arrest of labor is not just an arrest of labor, but it's also associated with fetal distress. How do I know fetal distress? It is the CTG showing late decelerations. Whenever I am having a scenario now with a fetal distress and along with it, there is an arrest of second stage of labor, my most important step is to, because the station is below +2. If this station was above +2, I would have gone with C-section. But since the station is below +2, my best thing that I can do is do an instrumental delivery with a forceps. Always remember, forceps is better for fetal distress than vacuum. So the answer to this question becomes instrumental delivery by forceps. That's exactly all that we have to cover. Thank you for a patient hearing. It's been a pleasure being with all of you. As I said, I absolutely take all my heart out to reach out to everyone who has been here. It's my birthday, so it's very obvious that I'll be passionate to teach. But a big shout out to all who have kind of compromised a bit on your Valentine's Day. But if you are right now with your Valentine and watching this, nothing can make me happier. So lots of love to all of you. I'll be taking. Okay, last slide, Rimjim. Can you just show the last slide?
This one?
Just show the last slide. Yeah. I'll be just repeating this in short. This is the second stage arrest of labor. The arrest of labor can be found because of caput and molding that is found in the fetus. Also, this fetus is in distress because late decelerations are what you find. Late decelerations on the CTG is what you find as a direct consequence of uteroplacental insufficiency. Matlab, uterus is not able to supply or perfuse the fetus anymore. Whenever there is a uteroplacental insufficiency, the fetus will go into distress. That is shown as caput and molding. Plus, 45 minutes ho chuka hai, the second stage of labor has not yet completed, and this is now a bad condition. Arrest of labor with fetal distress. The answer should have been C-section if not the fetal station was below +2. Just say fetal station +2 ho gaya hai, you do not need to cut open. You can just do an instrumental delivery using a forceps. If this fetal station was above +2, anything like +1, 0, -1, you will deliberately go with you will spontaneously go with C-section. So that is exactly the case. And what about A? Yeah, I told you, we are not going to do LSCS because the station is +2. नीचे आ गया यार, काफी नीचे आ गया है, +2 आ गया है, तो हम निकाल लेंगे. ठीक है. अगर if this, see, I'm telling you, fetal distress at first stage of labor. no matter what, go C-section. Fetal state distress in second stage of labor. If second stage of labor में fetal distress है, check for the head station. अगर station +2 से नीचे है, go with instrumentation, instrumental delivery mainly with forceps. +2 से ऊपर है, go with C-section. If distress is in second stage of labor and there is a CPD, go with C-section. If distress is in second stage of labor and there is a sign of obstructed labor, maternal tachycardia, maternal exhaustion, maternal hypotension, maternal dehydration, and obstruction signs like Bandel's ring, go with C-section. So the only time you go with instrumental delivery for a second stage labor issue is if the station is +2 and the fetus is in distress. +2 से अगर ऊपर है, go with C-section. +2 से नीचे है या फिर at +2 है, go with your instrumentation with forceps. ठीक है? So thank you everyone. I would
Excuse me, I would
want
like to add just one thing. Why option A cannot be the answer? See, the fetal station is at +2, yani it has crossed ischial spine. We know that ischial spine ka jo stations hai, we have -3, -2, -1, 0. +1, +2, and +3. So if it is at +2, it has crossed ischial spine. Now we have learned, Dr. Navonil has really well explained that the ischial spine is the narrowest diameter of all, be it pelvic inlet, be it pelvic outlet, be it or pelvic cavity. So if the baby has crossed ischial spine, so that means it is good to go. It can go. If it has crossed ischial spine, which is the narrowest diameter, it can now further complete its normal vaginal delivery if we push a little bit. So in those cases, if the station is +2, we usually go with the vaginal delivery. We can assist that vaginal delivery by instruments using forceps or vacuum. Forceps is generally preferred because forceps is less harmful for the baby, while vacuum would be more harmful for the baby. So
vacuum, actually in vacuum deliveries, it increases the risk of intraventricular hemorrhage or intracranial hemorrhage, to be honest. So vacuum has a high risk of causing ICH, especially in babies who are in distress. We should never ever rule out the possibility of an ICH. So vacuum can lead to a predisposition of ICH, which is why we do not go with vacuum. So I don't think there should be any more doubts because I've taken your individual doubts in the sessions. The only thing I couldn't take up is shock after delivery, which I won't be able to take up in this session. I'm so sorry, Dr. Gautam. But the remaining things are as it is. And I really thank everyone who has been there. I also thank Dr. Rimjim for being an active part in these slides and explaining everything so well. I mean, the part of AMTSL and retained placenta that you took were absolutely phenomenal. So thank you so much. I would give it over to Vijay sir now.
Thank you.
To conclude the meeting.
Thank you, doctor. Thank you so much. I believe there will be no questions because whenever it's your session, we have been seeing that kind of interaction between you and the audience that there will be no questions at the end. But still, on a hindsight, if anyone want to ask any question, the chat box is open for you. Meanwhile, I'll just drop certificate registration link on the chat box. You can all go there and register a certificate. You'll get your certificates through the mail. I just want to add one more point here. The moment you click on submit, give it 5 minutes time, the certificates will be delivered to your email. If not inbox, it will be on your spam. Please do check. One request from my end would be, please submit your form properly, check your internet session, submit it properly. In any FAQs you have, any queues, I know you got all answers to all your queues, but still if you want, you can, if any small questions or small doubt if you have, you can drop in the chat box. The chat box is active. Many says thank you. Good explanation.
Thank you so much. It's been an absolute pleasure being with all of you. Thank you.
Great. I think there is no question. Yeah. Thank you, Dr. Navonil. Thank you,
Thank
Dr.
you.
It was undoubtedly, let me make it very clear, it is undoubtedly one of the best sessions we ever had. And I am damn sure that all attendees here would agree with my statement without any question. Thank you so much. Thank you for the session. It has always been pleasure to have you on classes, Dr. Navonil. And today we had a special guest called Dr. Rimjim Rastogi. Thank you so much for Dr. Rimjim Rastogi. I would
welcome.
Extend heartfelt welcome from Mediversal Academy for all your efforts. There is no measurable way to measure your efforts for the today, being at the staying connected till 9:30 late night. It is something we can't measure. It is only shows that how committed you are to the community, committed you are to education. And Dr. Navonil, I just want to add one point. The session will be as good as its speaker, and here we have no question with respect to quality or the way you teach. Thank you so much. Thanks for the session. And
Thank
uh,
you.
want to add one personal statement here. Being on a birthday, I would have not even touched my phone or my laptop. So I know.
Actually, no. This is something that I try doing every year. I try being a little contribution in whichever way possible. If I'm in my hospital, I try, maybe seeing kids or try being around kids. If I am not in my hospital duties, I would rather love teaching. So it's usually something which I love doing, and I try contributing as much as I can because I think it's just a relay race. Whatever we get in life, I just try passing on the same blessings which I've received from my teachers, and
Great.
I think it's more of a relay race. I think the profession is always bigger than us, and the legacy should continue. So, yeah,
Completely agree. Very well said. And behalf of everyone here, behalf of Team Mediversal, behalf on all the attendants here, I wish you many more happiness of the day, and you should have abundance of success and keep training us. Keep training our doctors. Keep what you good at doing. Just keep it doing. And thank you for joining, having making happening this today. And meanwhile, doctors, please. Uh, I will be pasting the certificate link again for your accessibility. Please click on the link, fill the form. Your feedback means a lot to us. Uh, Please do fill. And doctor, coming back to you, I have been working with you from quite a long time now, and no matter what, whenever we have a call, you always talk about teaching. You always talk about upgrading content. You always talk about what betterment we can do. So it has been reflected all of your webinars. I don't think there is a way to thank you, but all we can say is let's keep doing what we are doing,
yeah,
and it's
absolutely.
the souls. And thank you so much.
Thank
Yeah,
you.
the Twinkle says wish you happy very birthday, sir.
Thank
Uh,
you. Thank you so much to everyone who's wished me. Thank you. It means a lot. Thank you. Stay blessed
Ravina
and lots of love.
Ravina says thank you so much, sir, and ma'am, a wonderful session. Happy birthday. God bless you, sir.
Thank you. Thank you so much.
Dr. Priyanka also says happy birthday, doctor. Thank you. Great. Okay. Now I don't want the chatbot. Okay. Now the wishes are coming in. I'm so happy. But yeah, Mohit Kesarwani says happy birthday, sir. Great.
Thank you. Thank you.
Yeah,
Thank
I
you.
pasting again the certificate link. Please do go fill out the form, get your certificates. Uh, this was a really great topic today.
Thank you. Thank you so much. Yeah, it's been an absolute pleasure. Thank you.
I am not from a background of doctorate, but this is something everyone should know. That should teach what moms can go through.
Yep.
Uh, yeah, this is. I was so. Whatever we do, nothing comes equal to our moms. Anyway,
Absolutely. Yes. Absolutely. I mean, this is the best thing that I can think of teaching, especially on my birthday, which is actually I mean, this is a tribute to all the moms. Actually,
very well
that's the
said.
best thing that they could have done, given us a life
They
and
are.
a life to live. Yeah.
I wouldn't imagine my life without my mom. I mean, oh my God. Anyway, let's come back to this. The session is great. I think we'll end the session. It's already
Yeah.
been,
Yep.
yeah. So people still
Uh,
Sure.
online. Let me also
just
tell you that.
let me have a vote of thanks. Thank you so much, Mediversal team, and thank you so much, the brilliant students who were attending. And I'm really glad that I got the opportunity. I would also like to add that this is my first webinar, so I was kind of very nervous, but thank you so much for giving me the opportunity. Thank you, Mr. Vijay. Thank you so much.
No, no, please not me. But anyway, you didn't sound your first timer because you were completely on track on everything. But thank you, great session. Thank you. Would love to have more such session. And doctors, we have planned a lot of webinars. This is one thing about Mediversal Academy. I can tell you with all the pride in my statement. Mediversal is one such, I don't know what to call, organization, institute, a community, because we keep on conducting these kind of webinars without having any paybacks or anything. So please do attend our webinars. Please do share with your fellow doctors. We are here to spread the knowledge. And thank you for joining. Happy learning, everyone. Have a great night.